Kerala Society of Ophthalmic Surgeons. We have been conducting CME online CME programs really regularly for the past 1 year and a half, so this year we started with this program, in which this is the third episode of the same program. Here, what we have tried to do is to get the different hospitals who are training the young ophthalmologists cataract surgery. So I've decided to concentrate on cataract surgery only the fellowship part of cataract surgery only in this program. And what I requested each hospital to describe are the different training programs available there: long-term, short-term, very short-term, and also explain regarding the stipend that they get there, the leaves that they get there, and if they do well enough, and if the institution asks them to stay back there, so what are the opportunities, what are the growth opportunities there? So to cover everything, see why I thought about this program. That's what I explained to all the chiefs of whoever is there from the different top institutions in India. See, I already had 2 programs. We've covered about 13 different eye hospitals from across India. We started with Arvind Eye Hospital. So we had RP Center, we had Sankara. Covered. We had 2 hospitals from Chitrakoot. We had 2 hospitals from Calcutta. So what everyone has explained is what I've just told now. And from RP Center, I'll give you an example from RP Center. What they did was, so they explained regarding the RP Center model. See the wet labs that they do, how they progress from. See, in the wet lab, what they do is they have a program where they have to initially do an ECC. Once they do an ECC, they get a certificate for that. Only after they get a certificate for that, they do phaco on the God side. Then they get the certificate for that. Then they are allowed to do supervised on human eyes. So different hospitals have different modalities. Arvind has their simulator there. Those 2 young ophthalmologists from Arvind explained how they help these young ophthalmologists in surgery with the simulator. So this is what has been happened during the past 2 episodes, and today we have a few of the other best eye institutions in India, including Shah, Nethralaya, LV Prasad, Draashti, Shroff, Uma, MN, LV Prasad. So we have another 6 top eye institutions in India. And who else to start with better than, you can't have anyone better than Dr. Smita from Shah, Nethralaya to speak on how the program in Shah, Nethralaya works. And why I said no one better than her is because she is currently the Director, Academics and Deputy Director, Comprehensive Ophthalmology and Senior Consultant Neuro-Ophthalmology at Shah, Nethralaya. And she has trained over 800 postgraduate students in cataract surgery. See, that's a kind of experience she has on training these young ophthalmologists. And she is in charge of comprehensive ophthalmology. She heads the Department of Community Ophthalmology, and she has led people of 40 to work seamlessly as a part of outreach program to deliver quality eye care. She has devised several innovative ideas for improving interactions between students and faculty. So, here we have Dr. Smita to speak on how the training program, the cataract surgery training program in Sankara Nethralaya works. And we also have an alumnus of Sankara Nethralaya, Dr. Mahesh. He is the Vice President of Kerala Society of Ophthalmic Surgeons, one of the real leading retinal surgeons in Kerala, in fact, in India. So thank you, Mahesh, for being with us. Thank you, Dr. Smita. Can you please take over? And
yes. So thank you for all your kind words, Dr. Sreeni. I think I will try and share my screen now.
Yeah, screen is visible, ma'am.
Yeah, so I hope my screen is visible.
Yeah, visible.
Yes. So at the very outset, let me just thank KSOS and Dr. Sreeni for inviting me for today's session. I have been working with Sankara Nethralaya for several years now, almost since the late 90s. And I've also been a past fellow of this wonderful institution. Today, I'll be talking on how we train our fellows, the focus being once again on cataract surgery as per the request. Now, first of all, there is an important question. Is fellowship actually necessary? That I feel depends entirely on the individual and their intended place of practice. There was once upon a time when there were very few institutes offering education beyond post-graduation. Now, of course, students are spoiled for choice. While Nethralaya offers a lot of fellowship programs, I'm just going to focus on the anterior segment fellowships because these are the ones where we have a lot of cataract surgery being involved. I think my slides are not moving. Just a minute.
Yeah, it's moving now.
Yeah, I'm sorry, I'm really not tech savvy.
Okay.
So the kind of fellowships that we offer include comprehensive ophthalmology, glaucoma, cornea, oculoplasty. We have these programs in 2 sessions, one that starts in January of every year and one that starts in July of every year. The numbers that you see below these names are the number of seats that are available per session. We also offer, I don't know why my slides are, yeah, there. Pediatric ophthalmology, uvea, and neuro-ophthalmology. Now, what's common to all these fellowships is that cataract surgery and cataract training plays an important role, irrespective of whatever subject they've come to study. There is a preliminary MCQ exam online, following which shortlisted candidates are invited to Chennai for an in-person interview. I'm going to focus only on our Chennai practices, even though we have these fellowships at Kolkata also. This is a brief overview. The long-term fellowship programs range between 18 to 24 months. Sometimes there's a clinical research component, in which case this duration can extend by 6 months. OPD timings or work timings are from 8 a.m. to 5 p.m., but these come with several caveats and they vary from posting to posting. All fellows have several duties to do, including eye donation calls and ward calls, OT calls, and emergencies. There is a lot of focus on punctuality, so attendance swipes are mandatory. There's a detailed duty roster that comes out well in advance, so that deals with all the nitty-gritties. We offer accommodation on a shared basis at a nominal rent. Stipend is at 30,000 rupees per month. Candidates are eligible for 14 days of leave per calendar year, and the organization will sponsor one national conference. All fellows go through an immersive orientation program that lasts for about a month. Fellows shadow seniors and experience all campuses and all duties firsthand before they're actually held responsible for anything at all. They are exposed to different aspects of the institution, including training in EMR, introduction to hospital infection committee, hospital safety committee, NABH audits, BLS training, labs, and of course, the OT culture in SN. Fellows undergo an orthoptics evaluation on joining so that any issues that need to be corrected can be done so at the earliest. One of my favorite aspects of orientation is a 1-hour interactive session on life and work ethics. We don't really talk about research ethics or publication ethics here. It's just like a moral science class, but it is a no-holds-barred discussion, and it's wonderful as a trainer for me to listen to the ideas and thoughts of the youngsters. We have a robust academic schedule, and we encourage all students to attend these classes irrespective of their specialty program. Each fellowship program has its own well-structured curriculum with classes, meetings, desired outcomes, and so on. And what they have in common, these anterior segment fellowships, is the training in cataract surgery. Moving on to the nuts and bolts. All anterior segment fellows undergo their hands-on cataract training in our community wing that's called the Jaslok Community Ophthalmic Center, or JCOC for short. They visit JCOC once a week, in addition to having a 2-month rotation there. 4 months if you're a comprehensive ophthalmology fellow. There's a shuttle service between the main campus and JCOC. At JCOC, students not only work as ophthalmologists, they also work as physicians. They examine the patient as a whole. Coming to cataract surgery, All our fellows undergo sequential training, that is conventional ECC, SICS by the Blumenthal technique, and finally progress to PHACOS. We still believe in training students in conventional extracapsulars. It does offer benefits in the form of learning to suture, learning to manage complications in a large open eye before going in for closed globe surgeries. Each time they learn a new kind of surgery, students have to undergo a period of observing and assisting surgeries, followed by a viva, which they have to clear before they're allotted their cases. They're expected to be aware of all the relevant pre-op information, right from the patient's name, systemic health status, and to eye health. Each and every surgery is supervised by a scrubbed-in trainer. The supervisor decides whether the candidate can do the entire surgery or needs to learn it stepwise. Now, though fellows are qualified ophthalmologists, several times they are not very well trained. They need to learn surgery right from the basics. Either they haven't had enough exposure, they haven't had enough experience, or they simply haven't learned the techniques well. Many times we find that they need to unlearn things to relearn them. So numbers really don't matter, because even if someone says they've done about 200 or 300 surgeries, I think as instructors, all of us realize within the first minute or two of a student's surgery, observing a student's surgery, we can gauge their surgical skill fairly well. JCOC has its own dedicated team of supervising surgeons, but we also have a panel of consultants who come from all our other branches, and they are involved also in training these fellows. This exposes the students to a wide variety of techniques as well as surgical tips and tricks. Students are given ideal cases, not only that, so that they can build up their confidence as well as competence. The extent to which they're allowed to handle intra-op complications, however, depends on their skill and the supervisor's judgment. Now, our students do go through a wet lab, but it is not a one-time process. It's a continuous and ongoing process. So we don't have any log specifically for wet lab. They don't have to do any X number of practices or processes before they get onto the human eyes. It's anytime they feel the need is required, they can always come back to the wet lab. It's always open. So we use wet lab to train them in hand-eye coordination, suturing, incisions, tunnels, and so on. So we use foam or rubberized sheets and animal eyes, goat size, for this process. There is a simulator that helps them learn controlled CCC and steps of phacoemulsification. As mentioned, wet lab training is continuous and need-based. Our fellows are also sent along with the mobile eye surgical unit to remote interiors of the state. This gives them an exposure to village problems in villages. They have to deal with a large number of outpatient department here. They're also sent on regular post-op camps. This improves their clinical skills and confidence in managing large number of people. Our students have a brief stint in handling independent OPD as well as OT in our peripheral center at Sri City. After training and all, how do we assess? Assessment plays an important role in training, right? So our assessments are once again continuous. They include both self-assessments as well as those by mentors and consultants. All fellows maintain logs, both surgical and clinical. And this is periodically checked by their department heads. This log is not just a numerical thing. It doesn't just enumerate what all they've done, but we also have an interesting concept where they write 5 things or 5 interesting things that they learned that week. At JCOC, there is an intra-op complications register that is maintained. This is gone through by the head with the concerned students. So they discuss the particular complication, how it was dealt with, how it could have been avoided, and other methods of managing complications. All consultants also assess their students periodically. This is called a monthly assessment form, and it is including aspects of clinical knowledge, surgical skill, and more importantly, interpersonal behavior, including communication and approach to patient and patient care, how good they are with teamwork, and so on. Now, I'm a huge fan of feedback. So I conduct an annual exercise where the students grade us, that is the teachers. It's only fair if we grade them, they should be able to grade us. And it's a good way of finding out where we stand, how we need to improve. I also share the results, the analysis, and the action points with them. The other process I conduct is an exit interview with all fellows. Probably it's not good to have only an exit interview because this batch is anyway graduated, but it will help. Their suggestions do help us train, alter the program, and improve the program for the incoming batch. We have something called a complaint and corrective action log. This is in case any students have issues with each other, a student and a consultant have a problem, or it could be even a consultant having a problem with the student. So there's a lot of two-way learning happening and a lot of understanding between the students and the consultants. The approach to everybody is approachable, and people are free to talk about. They're free to talk with their mind. With an aim to make learning more wholesome and interesting, we have some fun elements like question of the week, which is purely clinical ophthalmology based question. And the winner's name is put up on the board, and we have some small candy prize, something to keep them motivated. There's also something called IQ, which stimulates out of the box thinking, and it's more concerned with neuroscience of vision. Sometimes I even use silly rhymes to help drill in concepts better. We're constantly on the move, to learn how do we engage with juniors. Teaching somebody who is like 20 years younger to you and connecting with them is a challenge I wake up to every single day. And it's a lot of fun. SN is not all about studies though. We do have some fun events for students that have nothing to do with ophthalmology, like the year-end quiz, which is a mix of current affairs and pop culture. Then there's an idea fest, which is entirely planned by students and showcases their extracurricular talents. But coming back to cataract surgery and training, I'm just going to put up a few statements that I requested our ex-students to comment on, how their exposure was and what they felt about the training program. And if these testimonials are anything to go by, then I feel we must be doing something right. So there's one thing that says their numbers don't matter. And I also believe in this because Nethralaya is not really known for giving too many surgeries. They've always been a little less compared to other people, or so we've been told. So I believe that, some people are confident after 5 surgeries, some people are not confident even after 50 surgeries. So numbers really don't matter. What I like is the person who said there's a solid foundation, so that has given you the confidence to move on. Here's someone who said consultants don't stand only by your side, they actually stand by your side port and teach you every single step. There's a lot of passive learning that happens because yes, you do learn a lot by observing your seniors and other consultants and learn from them. You should realize this and internalize that learning. There are people who say that though they learned only the basics, within a year or so after graduating, they had the confidence to operate on complex cases thanks to the knowledge and expertise gained during the fellowship program. There's some people who also say empathy and ethics made sure that this fellowship program was a wholesome one. So finally, a little bit of advice. I believe the audience that is targeted audience are going to be students. So I'm just going to give them some advice, both from myself and from these guys over here, when you're looking after patients. Mark Twain once said, the difference between the right word and the almost right word is really a large matter. So choose the words you say to your patients with care. Much better to tell them that dilatation drops will relax the muscles rather than paralyze them. Zen masters advocate listening well. Only about 7% of our communication is verbal. So we need to learn to identify non-verbal cues. The 5 ways to listen are facts, emotions, body language, how the conversation is affecting you, and what is not being said. Especially in these days of EMR, we're all the time focused on the laptop or the desktop, and we're not really focusing and concentrating on the patient. We should do that. From Aphrodite, of course, learn compassion. And reframe Descartes' cogito ergo sum, I know, therefore I am, to I feel, therefore I am. So in short, the secret of the care of the patient is really very simple. It's just to care for the patient. Finally, I just like to leave you with this impressive statistic to think about. Self-discipline is the single most predictive factor for future success. So youngsters, remember, there is no shortcut in life. There is no substitute for hard work. Thank you for your time and attention. I am open to any questions if you have any.
Thank you, Dr. Smita. Can you switch on your video?
Yes.
Your video is okay. Okay, ma'am. Thanks for that real great overview of what is happening in Nethralaya. I have a few questions. Do you make use of the video recordings and do you analyze on them when you're assessing? And is there something like Oscar scoring method that you use for?
Yes. We do have Oscar scoring for all the surgeries, and we do not actually right now analyze videos. We are in the process of getting recording facilities for our community setup. So,
okay. So what have
we do ask them to see other videos that are available already and go through that, because it helps to be prepared before you come into the OT. Now there is so much of resources that are available online, right?
Available on YouTube. Like
yes.
I said, like I've sat through half an hour of
yes.
about 13, 14 See, most of them are actually using the video recording.
Yes.
Then and RP Center, they're telling like they take just the sections
Yes.
of all the fellows.
Yes.
And just go through each of their sections, so that they learn from others' mistakes, and so that
That's
I
a very
felt,
good thing, actually. If you can do it regularly
yeah,
and have somebody who mentors, who's able to sit with the student and go through it, it will make a lot of sense.
yeah. And do you have a simulator there?
Yeah, we have a very simple simulator which does for Rexis and phacoemulsification steps, but we were part of the Help Me See program also. So Help Me See was a SICS simulator, right? So some of our students did go there.
Okay.
And we're part of the original pilot study.
So you have the simulator in your hospital?
No, we do not have that simulator now. We have an old one. It's called VR Magic.
Okay. So I've really and as I said in the beginning, and this I've been asking to everyone. The idea for me to start this program were the young women ophthalmologists who really don't get a chance to do the go for fellowship, because many of them get married at the end of the third year and they have kids. Right. So do you have any leniency for girls who are doing a fellowship there when compared to the boys?
No, there's no preference. There's no gender. Once you become a doctor, you're a doctor. We go by that thing.
Okay.
We can give you a certain extension, but otherwise, no.
Yeah. Actually, Smita has highlighted a lot of important points. What I would like to add is, see, fellowship is not only the number of surgeries. It is working with some great people and learning from each of their communication to the patient, how to give bad news. In fact, I did VR fellowship in '99, so I worked with some of the greatest surgeons like Dr. Tarun Sharma, for example. The way he used to communicate with the patient, even now I do with my patient. Yes. How to give a bad news, how to talk to the patient positively. So this is not just cutting or number of cases only. So that is one thing. And the second point is each person is different. Like some may have already done 500 cataract surgeries. Some may, because of COVID, some might not have even done few steps also.
True.
So don't, everyone cannot run in the same league. So I think each person has a learning curve, so you have to assess yourself and modify your learning curriculum. It is not like 1 month how many cases you will give. Now, yes. Unfortunately, a lot of people are asking, in 1 month how many cases I will be able to do, as if in 1 month, even if I do 100 cases, I will do everything well. It is not like that. That life is little tough outside, so you need a tough basic education. So other things Smita has already told.
Yes.
Yeah, Mahesh, like see, why do we come to the issue of numbers? It's like see, Arvind, Sankara. See, after RP Center, I did my fellowship from Sankara, and probably in those 2.5-3 years I was there, I did about 22,000-23,000 cataracts. So, but now, I mean, maybe I was one of the most pampered fellows in Sankara, and because I was from RP Center, and it was Sankara was just starting to come up. So that is it. Now even there, the numbers have come down. They're restricting, and definitely the stepwise learning.
Exactly. Sreeni, I still remember the first day in OT, I started sclerotomy and all. My consultant was standing beside me and telling, your focusing is wrong. Your focusing is wrong. Small things. So I still remember all those things. So it is not I feel the basic training is excellent. So that is why.
Thank you. Actually, one thing, Nethralaya is a little different in the fact that we don't give preferential treatment. If somebody is a good surgeon, they get more surgeries. We don't do that. Everyone goes through a similar amount of surgeries. So everyone gets the same amount of surgery. So maybe it's bad for the one who's a great surgeon because they don't get, many more numbers than somebody else. But the one who's a slow learner also picks up.
It is excellent for average surgeon, average people.
Yeah, but
because they will learn.
We did get reference. Let's not talk about the other institution, because and each institution has its own
its own way of working. True.
Yeah,
it's correct.
And see, one more thing that I would like to know from you. You said somebody who has already done training from elsewhere. That part of training is not really considered. They have to really start from the scratch. But what if somebody is already skilled enough? So do they get a?
They might probably get some non-ideal cases, like that. A slightly little complicated cases and all that. Yes, that way. But not that they'll get suddenly many more cases. No.
No, like the other people start from 0 and these people start from 25 for a 100-meter race. It doesn't work that way.
No, they'll eventually get.
There is another advantage also in Sankara Nethralaya. You don't learn cataract alone because it's a comprehensive ophthalmology. You learn the other part of anterior segment also. So that is another exposure that many places only in cataract fellowship they may not get.
No, see, you used to have a 3-month short-term fellowship.
We used to have a 2-month program. 1 month SICS, 1 month FACO, but we haven't revived that after COVID. We don't really have any plans for that right now, but we'll look into it going forward.
Actually, this is one more reason why I have done this, to really ask for, like, I asked Narayana people and Dr. Rohit, I met him recently, and he said, yes, Srini will consider that, because see, that's something that we can, how we can help out these kids, because these COVID years has been really bad. They were not able to even touch one case. Like if institutions like yours can actually help, then it would be great, because you can understand a whole generation of ophthalmologists not having gone through any surgical training during those 2-3 years.
Yeah, to a certain extent, it also depends on highly motivated trainers. We need to get them to come and supervise somebody for a short term. Everybody is not willing to do that.
I was fellow at Shankar Nethralaya in 89-90, and I was trained by Dr. Badrinath himself. It used to be a non-formal environment during those periods. So he used to take us everywhere, including Sunday, wherever he goes, either Kanchipuram or some weddings or some funeral. I used to go with him for 24 hours. So it was not a training only surgery or clinical, but 100% everything. What he does, he wanted us to do.
Yes, that is so true.
That's great. Like, and last question.
Yes.
How do you actually support those kids who have really done fellowship or passed out from there? Like, see, for me, from RP Center, my teachers do really take care of me in many ways. Sankara, again, like whatever. So what is the support system that you have?
We just have a good alumni network, and we do put them in touch with people who can help them out. But there's no direct hand-holding after the fellowship. We used to call people from companies like Alcon and all to give them some idea about private practice and have a talk with the fellows and all that. That has not happened after COVID, though. Things have changed now. So.
No. Everything has to go back.
Yes, it will. I think it will. We're almost heading back. Yes.
Yeah. And please consider those
short-term fellowships. Yes.
We from the ground, we know what is the need for all these kids. And thanks a lot, Dr. Smita. It was a really wonderful presentation. Mahesh, thank you for that.
Thank you.
Thank you for having
sharing your experience. Thanks a lot. And now we have Dr. Sima Das from Shroff Charitable Trust Eye Hospital. And I think I have Dr. Sima's. Okay, Dr. I'm sorry about that. Like, I'll just leave that. Dr. Smith, Dr. Sima is trained in ocular oncology and oculoplasty from LV Prasad Eye Institute, Hyderabad, and she has done her post-graduation training from MAMC, and she did her MBBS from LHMC Lady Harding, Delhi, and she is a wonderful trainer. And see, how I came to call her was during my other session, the second session. So I heard from the consultant from HP Desai Hospital that they have a sandwich program. As I said from the beginning, my concentration and my focus for this program are the young lady ophthalmologists, because it's they form the majority, and the consultant said, like, it is they have that program basically targeting the young women, and Shroff Eye Hospital is another hospital which has the same program. So I called up Dr. Sima, and she's kind enough to present their training program for cataract surgery for the young ophthalmologists. And Dr. Sima, can you please take over and start your presentation?
Thank you very much, Dr. Sreeni, for the kind invite, and thanks a lot, Kerala Ophthalmic Society, for having me here. It's a privilege to share our experience and also listen and learn to what everybody else is doing. So I am not a cataract surgeon. I specialize in oculoplasty and oncology, but I look after training because that's my passion. So I will be talking about what we do, how we train, and I'll focus mainly on the model that we follow without going into the technical details, which I'm sure everybody else will be able to talk much more. So, Shroff, as you know, is we belong to North India, and I can see most of the institutes. In fact, in India, most of the training institutes are concentrated in the southern part of the country, where a lot of structured training is going on. Of course, we have RP Center in the north part of India. We have PGI. We have many other good institutes. But if you talk about fellowship programs, it's the South India, which has been the leading guiding the path for rest of the country. So Shroff, we have the fellowship programs. We offer subspecialty fellowship and as well as comprehensive cataract. You can call it by any other name. Earlier, we used to call it cataract, comprehensive after that. And subsequently, we have actually renamed it to call it a medical officer program. There is a reason for that, which I'll talk about in my presentation. We also have a residency program, DND program, which we have started very recently. It's just about 5 years we have started. So we are new to the residency, but we plan to kind of, step it up further as we are now more comfortable with a residency program also. So our education department has been in existence for about 15 years now, and we offer long-term fellowship in various subspecialties, in all the subspecialties of ophthalmology. And these are mostly 2-year program or 2-year 6 months program, depending if there is a research component, which is also part of it. So most departments are now offering research, 6-month research program also as part of the fellowship program. So it gets extended to about 6 months more and becomes 2 years, 6 months. Otherwise, the comprehensive fellowship program or the cataract fellowship, the cataract focused fellowship program is about 2 years duration, which is again extendable to 6 months more, depending on some special circumstances, which I'll again describe. We also short-term fellowship program in all the ophthalmic subspecialties, which can range from 1 month observership till about even hands-on training, 3 months or so. And we also have ultra short hands-on workshops or the training programs, which are essentially targeted towards the practitioners who might not have time, that much of time to kind of come for a long-term program, say 3 months or 6 months or so. So these are very focused, essentially either disease-oriented or surgery-oriented, very small 3 to 4 days of workshop, very intensive ones, with the idea that somebody versant who has a patient load, who already wasn't with basics of the disease or the technique and need some refining, they can attend those and start practicing in their own practice. So these are the various training programs with the qualifications. We have 2 sessions for the long-term fellowship programs. We start in January and July, and the interviews are held in the first week of December for the January session and the first week of June for the July session. So these are for the subspecialty long-term fellowship programs. For the comprehensive or the cataract programs, which we call the medical officer program, we have actually intakes 4 times a year. So every 3 months, we have a small batch which joins the program, mainly because their numbers are pretty high. And also they need much more intensive hands-on training. Some hands-on courses, there's some snapshots of the courses that we did last year. So every specialty have a small 2 days or 3 days courses based on either particular surgery or based on a particular disease, like say diabetic retinopathy or phacotrap or DCR, ptosis, and these are usually announced over the website or in our social media sites. And essentially the practitioners are the target groups who opt for those courses. So I'll be focusing mainly on the cataract training program. How do we, in fact, starting right from why there is a need for good quality cataract training, before we even go into the details of how you train and how you evaluate, because I think that's the most important part, to identify the need, identify the correct candidates. Otherwise, even if you train somebody who can do a very good quality surgery, but that if that is not getting implemented in the practice or in the community, then again the training, the impact of the training is not as much as you want. And a little bit about the outcome. You all know about the rest of the ophthalmic residency in India. Very few institutes like RP Center, Shankar Nethralaya, LVPEI, and many others in the country. In general,
Dr. Sima, your voice is breaking. What we can do is you can cut off your video so that the voice. Yeah. Okay.
Is it better now?
Yeah, it's better. It's better.
So we know there is a large void of availability of good quality trained ophthalmic surgeon who can do good in cataract surgery. And though the residents are coming out from many institutes in the country, including both government and private institutes, more than 50% do not or cannot do any independent surgery even after completing the residency program. So that's not really a very encouraging scenario. And that's where the role of a good quality cataract training program, be it a residency program or be it a fellowship program, comes into the picture. So at Shroff, we have a residency program. We also offer the training program, and I mentioned 50% are surgically inactive, and we have a huge disparity if we talk about the doctor and ophthalmologist and the population ratio in the country, and more so in the northern part of the India. Probably the picture is not as bad as in south, but at least the geographic location where we are surrounded by UP on one side, Haryana on the other side, and going further, MP, Bihar, where the picture is, maybe this is the average picture of the country, but if you see those particular state, it might be even, this ratio going to be even much more. So this is where our need for having good quality trained cataract surgeon came into the picture. So government has started many institutes with good infrastructure and paramedics, but I think the challenge everywhere is having good quality doctors who can help or who can use those infrastructures. Paramedics are a challenge, but there are programs now which are trying to kind of fill up that gap. So what we are trying through our cataract training program is to fill up the gap of the availability of good quality trained ophthalmologist, which is basically the missing piece in the circle, which is going to help us give good comprehensive care to the community. Right. Yeah, so this is where we are situated, and we are surrounded by some secondary centers also. Delhi is the main hospital, and we have secondary centers, which are essentially high volume cataract centers. And the bulk of the cataract training are actually concentrated on those centers. And we know the scenario, if you talk about UP, I mean, more than 1.5% of the population is visually impaired. And this is a little way of contributing to taking care of this problem in our near vicinity. So idea is to provide quality care in the areas of need. And with that focus, we renamed our cataract surgery program as the medical officer program. And we started it in 2015, because earlier the program, which was essentially focused on kind of, important surgical skill. But other things like which a doctor should be part of, like, managing teamwork, management, a little bit of management responsibility, and many other aspects were not really getting covered in those programs. And the other model was that, while you are getting trained, you also need to serve. And this is one of the way we can fill up this void of the availability of good trained manpower in the community. So you get trained and you give back the areas of need, maybe while getting trained itself and afterwards also. And we increase the remuneration, the stipend, which is usually given to the most of the fellowship, I know, like, this is a very, not even pocket money for many of the youngsters today. So we increase the remuneration to be at par with a entry-level doctor who maybe starts their practice, so that it becomes a win-win situation for them. Somebody who is coming at the age of 27 or so after finishing residency to do a further fellowship, that is also the time when they have to take care of their family also. So most of the people, especially those who do not belong to very affluent sort of background, are not able to afford to continue further training beyond that period, beyond the residency period. But if you give them a good remuneration, there is also an incentive for them to get trained, improve their quality of, their skill levels. At the same time, it doesn't put too much of pressure that they have to kind of take care of the family also. The leave policies we made a little more flexible, and because they are going to be mainly serving or getting trained in the satellite hospitals, which are not really in the metro cities. Most of them are in the second or the third tier cities. So a little flexibility actually helped us have more demand for this program, and we had candidates who were willing to take up those positions and also willing to go and serve in those locations where there is a need for good cataract surgeon. Now, we were just talking about, the quality. It's not about the surgical skill which a doctor should have when you talk about training. It's about many other things. They need to be competent surgically, but at the same time, there need to be some alignment with the values and the culture of whatever organization that they are serving. There has to be a quality element. I mean, without that, no program can be adequate. There has to be some stability. They need to have the little administrative skill also, because whether we like it or not, every doctor has to be an administrator, whether they run their own practice or they are kind of working in any organization. Some amount of administration is part and parcel of every doctor's job. And most important, they need to be team player. It does seem like as if we are asking for the moon, but we try to incorporate some of those aspects into those programs with the idea that there will be the trainees while in the program they spend about a year in one of the secondary centers. So it's a win-win for both the candidate as well as for us, because we have a good quality trained manpower available at the center, and at the same time it brings some stability to the center. So there is one person who is there at least for a year or so, and that brings some amount of stability in the working of the center. Pros are also that there are very high volumes, so that's a motivation for them to learn and see high volume outpatient as well as surgical work. And simultaneously having, they're not really employees, they're still our trainees. So they are more amenable to monitoring and mentoring, which sometimes is not possible if you just hire somebody as a faculty. So that monitoring, mentoring thing sometimes becomes a little difficult. There is a high need for training because most of these participants are very raw. Some have not even done single cataract surgery during their residency. They need to be really watched and monitored. That needs a lot of input from organization side. And of course, we always had that apprehension of having some conflict with our fellowship programs and the fellows in training. But subsequently, we found that that is something which we could handle with some intervention. So train and serve is what the model of cataract training is for us. As I mentioned, the recruitment for the medical officers are every 3 months. And we preferentially tend to recruit them, not really from, the metro or there might be somebody who is very smart, very academically very sound, but we know that this person is not going to go and serve in a community where the skill of a cataract surgeon is required. So generally the preference is given to people who might belong to sector 2 or, third tier towns, who might not be very smart in terms of, spoken English, academic skills, or even sometimes theory. But if we know that this person is going to go back to the community and serve, so that person gets a little weightage when we do the interview. So the selection is via a written test, so that there is some baseline theory knowledge, which we know that that person has. And then we conduct an interview, and based on the interview and the written test scores, they are selected for the program. And essentially, the candidates who are aspiring to settle as comprehensive ophthalmologists in the cities of origin are sometimes given preference. And maybe they are the people who are a little less inclined to a specialty fellowship, because once you do a specialty, your work profile becomes limited to maybe a little metro cities or bigger hospitals. But idea of a cataract fellowship program is to have people who will go back to the areas where there is a real need. Subsequently, we also included some amount of specialty training into this program itself, because COVID actually taught us a lot of things. So I will again discuss about it in the subsequent slides. So these are some of the cities from where most of our cataract trainees tend to get recruited. It's very widespread. And as you can see, most are from the non-metro cities. So this is how the program is structured. It's a 12 months program, which is extendable to 30 months, depending on whether the candidate opt for some basic subspecialty training, or we feel that the candidate is suitable for some basic subspecialty training. The initial 3 or 4 months is a very intensive hands-on training after a orientation. They get posted, they remain in Delhi at the base hospital, where they are taught the basic SICS surgical skill. Initially, we used to start with ECC, but then subsequently down the line, we realized it's only during the initial 3 months they do ECC. After that, they have never done a single ECC throughout the course of the program. So we have shifted and kind of started with the SICS after that. They also get a little bit of idea about the basic diagnostic related to cornea, retina, and glaucoma, because these are the specialties where they need to know a little bit, even if they have to do cataract. Many of them will have implication even while managing the cataract also. So that aspect also we try to cover within these 3 to 4 months. Subsequent to that, they get posted in one of our secondary centers where there is already a faculty posted, full-time faculty there, and their subsequent surgical as well as outpatient clinical supervision is done with that particular faculty, with mentoring from the base hospital, from the education department here. So and once they're comfortable with SICS, so they have done about say 300 to 400 SICS, which could be 6 to 9 months down the line, depending on the skill level of the individual. They come back to the base hospital for an intensive 15 days to 1 month eco training. The Edakhlon PDP program is also incorporated. So they undergo PDP for 15 days, and 15 days they undergo training with our own faculty here. And then again, they go back, and their subsequent leg of the posting is they kind of start doing phaco surgeries in a stepwise manner as per their credentialing. And that's the time when if we feel that somebody has interest in learning basic subspecialty, which might be say for example somebody is doing cataract, but in the practice when they subsequently go to their practice, they will need to handle a little bit of say medical glaucoma also, or medical retina. So that option is given to them, and if you feel that the candidate is kind of based on some performance criteria, they're suitable to undergo a little additional training, we also offer them that in a sandwich model. So this is a sandwich model where each specialty have their own different curriculum, and we teach them some basic subspecialty skill depending on the requirement of the center itself, or depending on the candidate's requirement. So that's how the whole curriculum is. They kind of attend to comprehensive OPD, OT for especially cataract surgeries. They go for the outreach camps. They oversee the quality standards of the hospital also, because that's also a very important learning which they need to be aware of while they go to their own practice. They're involved in the training of the paramedics also. That way kind of they also remain in touch. They get trained and they train another person. That's again the model they follow, because then they understand the importance of the training. They are also involved in the implementation of the strategic plan, especially at the secondary center when they become a little senior. They also work with the administrator at each of the secondary center in the management, day-to-day management, some of the aspect where a clinician needs to be part of. And we encourage them to be part of community-based as well as clinical research, whoever is an inclination, but it's not made mandatory for them. So the initial 4 months, what we do when they are at the base hospital, they undergo very intensive wet lab training, and they're credentialed in the wet lab based on their direct supervision by either by the wet lab technician and the faculty in the wet lab. Their videos are also reviewed, and whatever step can be Oscar scored in the wet lab, those steps are Oscar scored. And when they have a score of independent, where they can do most of the step independently, we start their training in the OR in a stepwise manner. So these are some of the wet labs, and we use both, we have a dry lab as well as a wet lab. So we use the model eyes mainly for the phaco training, and goat's eye are mainly for the SICS training. We do have a simulator, but that's not something which we have used very extensively, because I think there is still a lot of scope of improvement in the simulator. Those who have used it feel that, we still need to kind of, improve on it before we can implement it for our routine dry lab training. So our OT model is, we have a separate dedicated training OR where these participants get trained, and we have a faculty who does not have a list for that particular day. So that faculty is only kind of, posted for managing the training theater for that particular day. And it's a very intensive hands-on training. It's that faculty is there for full day. And generally we train about 7 to 8 surgeons. These are very raw surgeons. So most of them tend to take about 45 minutes to 1 hour for one surgery. So that's how we have kept the figure of 7 to 8. And there is usually a roster which is made by turn. These participants, those who join for the initial 3 months SICS, they get to do almost every other day or almost every day. Sometimes they operate. The idea is at the end of 3 months, they are by and large independent in handling uncomplicated cataract surgery. So at the end of 3 months, usually they will do totally supervised about 40 to 50 SICS surgeries. And when you feel that they have a acceptable complication rate, their Oscar score is acceptable, and they are sort of can manage some amount of independent surgery with minimal supervision, and that's the time they are posted into one of the satellite centers. So we monitor their surgical steps. We use the ICU Oscar, and to make it more convenient, we have kind of made it in the form of an app, because initially we used to use the hard copies, but then we found that the whole purpose of this app that it should be real time. And if you have a hard copy, most of the time it's not possible to have a real time scoring. So we created an app where all the steps of each surgery, SICS, phaco, ECC, and there are other surgeries also. Oscar is available for many other surgeries from each specialty, like keratoplasty, vitrectomy, squint surgery, even for some oculoplasty. So those are all incorporated in that app. It's a freely downloadable app. Right now it is restricted to the Shroff users. You need to have a login and ID. It works on the Android. And once they start their surgery, they enter the details of the surgery into the app with the name of the trainer who is there on that particular day. And once the surgery details are entered into the app, the trainer dashboard, the trainer can see the surgery on the dashboard. And then it's just a click. You can just click and put the score for each step. So it's like you change the page. So, and every page has one step of the surgery, and all the kind of the rubrics are given in that Oscar itself. So that has made the scoring much more real time and more complete, I would say, which earlier was not very much possible. And based on the feedback, what we get from the trainee as well as the score, once we find that the participant is comfortable in most of the steps, that's the time when we decide to post them for their further training into one of the secondary centers. This is one bit which I wanted to focus, because it's not about cataract surgery. You also need a little bit of, basic subspecialty skill pertaining to cornea, glaucoma, and retina, because these are the things which are usually required for a cataract surgeon. So while they're getting trained in cataract, in the initial 3 months, we also give them 1 month rotation in each of this department. And we have a sort of, module created for each specialty. Like, for example, if they are posted in cornea, they need not know how to kind of, do a keratoplasty, which is not possible in 1 month, but they should know how to manage a corneal ulcer, which they might be seeing when they are posted in the satellite centers. How to manage a keratoplasty follow-up is again something, the suture management, small things. They should know how to do a scraping, which a comprehensive ophthalmologist should know how to do. Similarly, for glaucoma, they should know how to do a PI. More important, they should know how to do a good gonioscopy, how to identify the patient who needs a PI. Should be able to identify the indications for a PI, should be able to do a PI. So those kind of things are the focus. We use the OSEX and we have modified it to meet the subspecialty requirements, and that's how they are sort of, scored and graded. And the idea is that at the end of 3 months, they have a little bit of idea about managing some amount of subspecialty, medical subspecialty, I would say, also when they are posted in the outreach or the satellite centers. So quality of training is what matters. And they still remember that that's still a trainee, though they might be managing one of the satellite centers as an administrator also, because most of the time a doctor is on the top of the hierarchy if it's a secondary level hospital. So, but still, if since they are still a trainee or they belong to a training program, they're more amenable to monitoring and mentoring. So we do a monthly review of their complication, their surgical outcome, visual acuity, duration, everything. There is a very detailed review which happens with the trainer group every month. Their clinical findings, the file review and the file audit is done every month. Other things we take care about is their discipline and interpersonal behavior, where the feedback is taken from the faculty as well as from the the other colleagues in the staff. Their leave management, their OPT and OT starting, everything is monitored. The idea is that we need to incorporate a culture of discipline also, which boils down to a good quality outcome. These are some of the the format of the logbook that we follow for every month review. And while they are posted in the satellite center, periodically one of the faculty, especially when they start with a new surgery, when their credentialing changes, when they start doing a little more complicated surgeries, one of the faculty from the base hospital here does a remote mentoring also for the initial few surgeries. And this is something which we learned during the COVID time. And we realized that even sitting at Delhi, you can do a real-time monitoring of the surgery, which is happening in a remote center, say Mohammadi. So that helps us to actually continue our training during the COVID time, because the patients stopped coming to the base hospital. We didn't have any outreach or anything during the COVID time. But then the people who are in the training program, they were waiting to get trained. So we decided to take help of in fact, the LCON has helped us in that. They set up the system in the satellite center. Their CAS actually went there. And then the faculty was sitting here. We could see the surgery real time and then guide the trainees. So we had few people who were trained totally via the remote model on phaco surgery during the initial period, during the COVID time. And then we realized we can actually use it for the other surgeries also. So as part of the Sandwich Fellowship Program, we have actually started using it now for glaucoma surgeries also. This is one of our faculty who is actually doing a trabeculectomy sitting in the satellite centers, and Dr. Smita is sitting here in Delhi. She was monitoring the surgery real time. So technology has made a lot of things possible, which is probably one of the good things COVID has taught us when it comes to training. I would say a little bit about the LCON program, because LCON is part of the cataract surgery training program, but we have a standalone separate PDP program also, which the participants are recruited by the PDP team. And initially it was a 15 days training. Now it's about 11 days. And these are essentially practitioners, and UP is the focus area for LCON right now. So most of our participants actually come from UP. And their essential criteria for recruitment is that they should be able to give their data 1 year post-training. So 1 year post-training follow-up is required. And there is a standard PD course, which is basically for the pure SICS surgeon who wants to start with their phaco. It's 11 days, very focused, very intensive program. And then there are the enhancement and the advanced courses, which are mainly for the people who are already doing phaco, but they want to sort of, upgrade to maybe complicated cases or some, the refractive cataract surgery management and other things also. So those are again done, the recruitment done on a one-to-one basis. Based on that, they are asked to send some video as well as the logbook, and then the faculty reviews that, and then we decide whether this participant is eligible for the program or not. And we have been doing the PD program for more than, I think, 12 years now. We have trained about almost 200, and cumulative, they have done this mini surgery with almost 87% phaco. And these are mostly the practitioners who are mainly focused in the UP and the surrounding areas where there is a void of good quality trained phaco surgeons. So I think that's something which has worked really well. These are again the numbers. Now we have started including our own internal long-term trainees also, and we enroll them in the PDP program because that makes the learning curve very, very steep. So in a short duration, they can actually go from almost like a baseline to at least basic phaco, they become pretty competent. So in the medical officers program, we have about 34 participants we have trained via the 24 months program. We have 22 participants who are ongoing training, and on an average at the end of the program, they'll end up doing on near about, somewhere between 1,500 to 2,000 cataract surgeries. This figure is little, in fact, less, 250 phaco. Right now, they are doing almost about 400 to 500 phacos because the volume in the satellite centers has also increased a lot. Cumulative, if you see the figures, these are again not the very updated number. I think these are the last year's number, but pretty decent sort of, phaco rate with a very good or acceptable complication rate. So what about post-training? So once they finish the 2-year program, we give them the option of that you can become an adjunct faculty for 2 years at one of our satellite centers. So the remuneration becomes at par with the adjunct faculty, entry-level faculty. Some of the people who are already from those geographic areas, they opt for it. And in fact, 50% of our the people whom we have trained have actually joined back for some time at least with us at adjunct faculty and have served at least for 1 or 2 years. Some are still doing it in one of our secondary centers. So it's a win-win for us because we have a quality trained person whom we know. Sometimes the lateral entry, you don't know the quality of the person, and sometimes it becomes difficult to have an alignment to the organizational culture. So when you have a person who is your own trained, you know the skill level of the person, you know the attitude and the other things, it becomes easy for us also. It becomes easy for them also because they're getting a job which is close to their hometown in the own geographic area. And they're also kind of, advancing their skill while they're faculty. And post 2 or 3 years, they are free to kind of go and start their own practice wherever they want to. The other option is to go for specialty fellowship. Some of them do opt for a full fellowship. So if somebody wants to go for a full fellowship, one option is to go again for 2.5-year or 2-year program. But if they want to learn just basic subspecialty, like tomorrow if they want to go to their practice and then they want to learn some amount of glaucoma, instead of going through the old full program, they have the option of going through a 1-year program. And we make it like a sandwich model. Means that they can come to the base hospital for 1 or 2 months, learn some basic skill, go back and also start practicing those while they are already working there. The faculty mentors them from here, and then a few months down the line, they again come back here for additional advancement of the skill level. So the curriculum for sandwich fellowship is different for each specialty because the requirement is very different for each specialty. But that's the option which we give them somewhere when they finish their phaco and then they are comfortable with their phaco skill, because then they also feel that they're learning something extra. And they are not just kind of, stagnant and practicing the same thing over and over again. So that's an incentive for them also to sort of, stay back into the system. And it's again, in the process, we are able to offer some subspecialty service even at the remote satellite center areas also. But it's not an automatic thing. There are some selection criteria. There are some evaluation criteria. Not everybody is eligible. If based on some criteria, their performance, we feel that they're available, we offer them. And it's also based on the availability of the slot for the training in the particular specialty. And so change is always a necessity. And COVID taught us the void in the availability of basic subspecialty at the primary and the secondary level. In fact, that's how we started incorporating this in our the medical officer program, some specialty training, because these are the kind of cases we were finding during COVID. A corneal ulcer which has come with a total corneal melt, because simply at that level, rural level, there was no doctor who could medically treat a corneal ulcer properly. Earlier, this patient used to easily travel and come to a kind of tertiary level center. During the COVID time, they could not travel, and finally, when they could travel, there is a total corneal melt. So we need people at least who can take care of those needs at the primary and the secondary level, and that's what helped or kind of pushed us to train our own medical officer with some basic subspecialty skill. So we have now routinely incorporated it. We have redesigned the whole curriculum and incorporated it in the medical officer program. We have started training whoever wants to opt for what, and these are some of the people who have undergone the training in cornea, glaucoma, some in peds. Some are still ongoing, and it's not decent. Even after training, they could start, like, for example, this doctor undergone 2 months phaco trap training. He was already a good trained cataract surgeon, underwent about 2 weeks training in phaco trap and started doing trap in the satellite center under the supervision of the faculty, remote mentoring from here, and to do 64 traps within a year. So that is something for which also help the travel for the patient, unnecessary travel. If you can provide a service at the doorstep, not only cataract, but something additional, that's really beneficial for the community. So this is something which we plan to continue. We are talking about the sandwich model. So with Orbis, we have the pediatric sandwich fellowship program, which has been a pretty successful program. Like, we have this lady from Vietnam who had 2 kids who cannot come for a 1-year program. But then this is how it started. I think she was the first candidate. Orbis had a dialogue, and then they modified the program. And then they made it a sandwich where you come for maybe 2 or 3 months, you go back, our faculty goes to your center, train you in your setup, and then you practice what you have learned. Subsequently, few months down the line, you again come back for 2 or 3 months. So 2 or 3 months is something which is much more feasible for, especially for women, to kind of, spend time rather than spending 1 or 2 years at one go. So we have pediatric program is quite a well-established program now. I think we have trained almost 8 to 10 participants via the pediatric sandwich. Glaucoma sandwich fellowship program has been recently developed along with the Santian, and we are now offering it to, we have started with our internal candidates, and we are now open it up for the external candidate also. So these are both short-term program as well as long-term programs, and there is set curriculum, defined curriculum for each of the sandwich fellowship models. So just a reflection on the quality, if you have good quality trained surgeon, everything improves, including if we see our own center, before we started this supervised medical officer program, the visual outcome of the surgeries which are done by the trainees have improved drastically over the period of time. Post-operative, poor visual outcome has gone down, and the complication rates, post-operative infection rate, if I talk about complication, if we say only end of, that has gone down because they are now more quality conscious. It's not only the surgical skill, in fact, the quality of the surgery, including the infection prevention skill, they are now trained on those aspects also, the sterilization practices. So that makes, I think, a lot of difference when it comes from the top. Rest of the staff also tends to get aligned if you are also aligned with all those practices. In fact, Sightsavers are adopting this model, and they have started the Sightsaver fellowship program, which is essentially an adoption of this same model, and some of their trainees get the initial training. We are one of the partner hospital where the initial 3 to 4 months training is done, and then they get posted in one of the Sightsaver hospitals. We were talking about, all work and no play makes everybody a dull person. So it's all, there has to be some play also. So these are a batch of some of our cataract trainees. While they were on training, we had this Botswana cataract training campaign where, the government of Botswana had invited, we had a tie-up with them because apparently there is no cataract surgeon in Botswana. So to clear the backlog of cataract surgery, we had a 3 years, I think, MOU with them, where the team from Shroff used to go for a month or so, operate there. And it was essentially our cataract trainees who had handled the program with maybe 1 or 2 faculty in each batch, and they had done a fantastic job. And that gave them the confidence of also handling, surgeries in a different country, in a different situation. There were challenges which they could come up and, and ultimately this is something which is going to help them in their own practice also. And of course, the fun part was there along with that. So it's not only about surgery, they need to know, you need to have some other dialogues, other insights also. So training is not only about using, Dr. G.N. Rao always keeps on telling, it's not only about using your hand, it's about using your head as well as heart. So we keep on having those lectures, interaction with renowned faculty, not only from ophthalmology, but from various fields. And we don't talk about ophthalmology and cataract, we talk about many other things like, surveys and, inspiration. So this is, we call it the Inspire series because, you learn, you listen to them, to their journeys, and you get inspired to do, something beyond your routine work also. So trainers also need to be updated. So train the trainer workshops, essentially how to give feedback, how to evaluate. These are periodically done almost every 6 months. We have the train the trainer programs, which keeps on happening. We have external faculties who come and train. We have our internal workshops. Idea is to focus on the communication skill because giving a feedback is something which is very, very essential. And I think it needs training. Not everybody knows how to give a good feedback and an effective feedback. So we also involve the trainees or the participant to kind of, give a feedback on the training program also and the trainers. So the things become 360-degree. So we have the faculty coaching feedback form. It's an anonymous form. So anybody who has undergone the training can give a feedback about how the training was, how the faculty was while getting trained, what was the interaction with the faculty, how much guidance did they get from the faculty. And we shared this with the faculty also so that they can improve on the areas where they feel that there is, some of the things which might be lacking. So this is what we want to see at the end of the day. We need people who are not really very good trained cataract surgeon, but we need people who can go back to their respective places, and handle each and everything, not only with their surgical skill, but also rest of the other aspect of being a good doctor. So this is what makes us do what we do and inspires us to make things innovate and make things better every day than what we have done yesterday. So thank you for your kind.
Dr. Sima, can you switch on your video?
Yeah.
Really inspirational. This is the mind-blowing job that you're doing there, and the ideas that you brought in, absolutely wonderful. See, I have 1-2 queries only. The sandwich program, because see, I was talking to Dr. Rohit Shetty of Nethralaya. I just talked about the sandwich program, and I also asked him like they should have this short-term training program for those young ophthalmologists or who are senior ophthalmologists who just can't spare 1 year or 2 years for fellowship. So he said, Srini, you do one thing. Let's give me an idea as to how the sandwich program is done, and we should. I'll try to replicate in Narayana. That's what he said. Like, so how does it? How is the selection process and all for those who come for the pediatric sandwich training program? Because the other one is basically for in-house people, right? The specialty program. So for the pediatric sandwich program that you're doing, I think with Orbis, right? So for that, who selects those candidates, and how do you actually do that?
So as of now, the pediatric program is with Orbis, and essentially Orbis comes with the candidates. What we try to look at is if the participant undergo the training program, will he or she be able to go back and practice what he has learned or she has learned? So that remains the essential criteria. So if you have a pediatric ophthalmologist, or say if you have an hospital where there is a volume of pediatric work and somebody is interested in getting trained and start doing the pediatric work there, I think that's a criteria enough to take them. So I think skill is something which you can impart if the attitude is right, if the learning attitude is there. So that's what we tend to look at. Essentially, as of now, Orbis brings the need to us. Like we have this hospital where there's a very high volume pediatric work, and the hospital is very interested in getting one of their doctors trained in pediatric so that he or she can come back and practice, because that baseline is already there. And then that person undergoes an interview with us, and if we find he or she is suitable, then the enrollment happens based on of course, the availability of the slot and all other things.
So just 2 questions. I think we are straying into the time for Draashti Nethralaya. But anyway, say how do these kids get to know when the fellowship are available at Shroff, and how many fellowship seats are available every year, and what is the stipend that they get when they're doing long-term fellowship, and what is you said it's a good salary that they get when they finish the fellowship and join as a medical officer. So just if we can touch upon all these 3, 4.
Yeah, so the recruitment part. So for the long-term fellowships, I'm talking about the subspecialty. We have 2 batches joining every year. So one is in January and one is in July. The interview for the January batch happens in the first week of December. And for the July batch, it's usually the first week of June. So generally, a month prior to the interview, the flyers and everything, the information goes out to the website, to the social media. So those who are interested can just keep a tab on the social media as well as the website, and it will come out on that. Otherwise, wherever throughout the year, whenever we keep on getting the applications for a fellowship slot, we keep on compiling the email addresses and the CVs. We have a email bank of the people who have shown interest in the fellowship programs. So whenever there is an opening, even those participants will get the mailer. So if somebody is interested, simply can send in the CV. We have the training ID, training@sch.net is the ID. And then it becomes part of the, the bank of the email addresses where all information will go. For the medical officer program, we have recruitment 4 times a year. So we do it instead of doing twice a year, we do it every 3 months because the numbers are more. Every batch we take about 3 to 4 medical officers. And since they need very intensive hands-on training, it becomes very difficult to take 8, 7 people together because then it becomes too much of stress on the training. We have fellows also train, we have the residents also to train. And on top of it, if it's a very large, big batch together, then it's become difficult. The other reason we have made it every 3 to 4 months is that one batch actually finishes and goes from Delhi after 3 to 4 months. So then there is space for the next batch to kind of join in. So that's the reason we have kept that spacing. And as far as the remunerations are concerned, it's a stipend for the subspecialty fellowship programs. It's a very kind of nominal stipend, sort of a pocket money which they get. I think we are giving about 25,000 or so for the subspecialty trainees. But for the medical officers, they get a little better amount. It's depending on whether they are availing of the hospital accommodation or not. They get about 55 to about 65,000. If somebody is availing the hospital accommodation, there is about 5,000 HRA, which is deducted, and they get about 60,000 once they finish about 6 months or so. Initially, they get about 55,000. They have to complete. So it's like, every 6 months, there is an increase in their remuneration.
Okay. Thank you. See, I personally would love to do a fellowship in Shroff Charitable Hospital if I had to. The training program is amazing. The only drawback that is the stipend part of it. See, the problem, because I've gone through this problem. That's something that everyone has to realize. See, when I was in RP Center, that was in 2000. I passed out in 2000. My stipend was about 18,000 and 18,000 or 19,000. And when I went to Sankara to do fellowship, it came down to 3,000. And in 1 year's time, I had to get married. 3,000 rupees. See, these are some areas that you should consider, because see, these people have done MBBS, they have done their post-graduation, and they're in that age, like late 20s. So that's the only drawback that I've seen. But amazing training program. I would recommend your training program to all the young ophthalmologists, because our kids basically concentrate on south of India, as you said, but we have amazing training centers like LVPEI, Sankara, Arvind, and all. Amazing training centers. But see, I wanted them to get an idea about what is available in north of India, and this was really wonderful. Thanks, Dr. Sima. Thank you for explaining in detail your training process. I'm sure the different hospitals can exchange ideas, and this program is going to be beneficial for all. Sorry, Dr. Shreya, Dr. Mehul, we just.
No, you're fine. You can just continue asking question. No problem.
Yeah. Okay. Now, see, like it's wonderful to have you and Dr. Mehul. Are you two in the same room, Dr. Mehul and Dr. Shreya? No, that might be an issue, because there'll be an echo there. So either you join from the same laptop. If there are two laptops that are there connected to Zoom in the same room, you heard it right now. No, there was an echo. Okay, so
now it's not that, right?
No, it's not there. Now it's not. Right. Yeah. So first of all, congratulations, sir and ma'am, for the amazing work that you're doing in the rural tribal belt of India, where you're giving treatment for such low rates, and having done more than 1,25,000 free eye surgeries, and more than 9 lakh free patients examined, and a huge number of publications. Thanks a lot for giving time for our program. Sir, ma'am, can you start your presentation on?
Can I share my screen now?
You're not sharing, ma'am.
Yeah, I'm not shared. I'll share now. Is it visible?
Yeah, yes, ma'am. Yes, ma'am.
Am I audible?
Yeah, you're audible, ma'am. Just make it full screen. Yeah, that's great.
Thank you, Dr. Sreeni and Kerala Ophthalmic Society for allowing us to give our certain experience what we have in this rural, remote tribal area where 69% of population is tribal. So training and perfecting cataract surgery training opportunity, which have been given to us to share our experiences. And we all know, why do we need this training? Because 47% of the cataracts are responsible for blindness. And as NPCB itself says, 60% of blindness because of cataract surgery. And WHO report also says 21% it is even post-operative cataract surgery. So we did a comparative effectiveness of various postgraduate training models in India for ophthalmology, and we enrolled 45 residents from various institutes and organizations, including government and private institutes. And we saw that if we look at DNB and other trainees, we have seen that average DNB candidate performs for 97 cataract assisted surgery, where 948.3 average can be performed by DNB independent perform surgery. And if you look at other courses, what we have seen is only 76 average surgeries done independently performed with the other organization. And these are the more detailed data of the studies what we have done comparing this. So requirement of further training emerged, and can be just because of improper documentation, can be just incomplete logbooks, can be a limited surgical review facilities available, or permissions are not given to all the trainees to operate independently, or maybe the limitation could be simply number of cases. So prerequisite for any training institute who wants to offer training should have many more number of patients, number of trainers also the training institute should have, and not only the number of trainers, but skill of each trainers are also to be supervised and observed, and facilities also to deal with the complications of cataract surgeries, as we are told only to speak about cataract surgeries, but I'll tell about certain other programs we have, but right now we'll talk about cataract surgeries only. So facilities for fully equipped vitreoretinal department with highly competent full-time VR surgeon should be there. Along with that, eye bank or any other cornea retrieval program facility with competent cornea surgeon who can do dissect, delt, and along with that, if you have video documentation, that's a wonderful thing for the training institute. And also, we all know that when we are talking about cataract complications, it is really resource intensive. And the visibility also to deal with the complication is less just because of corneal edema or comorbidities with the cataract. And what we do in our Draashti Nethralaya hospital is we just gather and collect the documentation and certificates who applies for the training. We just ask for the goal of receiving this training. What do they want to do after receiving this training? And we just conduct the interview with applicants one-on-one basis. And once the trainee enters to the hospital, they meet to our admin department, where fees and stipend, documentation, duration, accommodation, everything is discussed with. And then they are also, along with that, we prepare our trainees, can be just for simple orientation to the best knowledge about the cataract surgeries. So the first thing what our trainee, when they enter into the institute, they fill up the pre-training assessment form by themselves. So sometimes that they are very well knowing that what they know, what they want to learn out of this, and they can compare when they go back. So this is the deep detail of pre-training assessment program. where we can ask each kind of skill they have and what they want to acquire from this institute. And the step 2 is a first dialogue with trainee is a director does, and that is a value of organization and institute, because we definitely tell on the first day that our aim of our organization is just to train you. We cannot provide the biological material. They have to be patient sensitive. They have to think that whosoever they are operating, maybe their parents only. Here there is not case-based training. We even on the application, when they ask, as previous speakers also said, they take an interview of trainer and they ask how many cases you will give. And that's the thing, we definitely reply that this is not a case-based organization. We want to train you custom-based, and whatever you want to learn, we'll definitely train, but they are not the biological material for us. They are human being for us. And that too, they have to go through the time discipline. The step 3 is introduction of a team and welcome to any of the trainee when they come to our hospital. And then we just give them a hospital tour. So they explain everything what a hospital does, ranging from reception to the color coding system unique we have in our organization, and what kind of work we are doing periphery. So from periphery to the highest technological part, LASIK center, they just go through the hospital training program, and they are just sent to the simple orientation to the OPD department, so they can see what we see under slit lamp and with the viewing system. So they must know what they are watching and what they are going to do. That is the visualization training. Then the step starts the simple instrument holding outside the operation theater. So this is the instrument orientation done to our trainees outside the operation theater. So they know how to hold any kind of instrument, and that's truly hands-on training. Once they do that, they practice on cataract training, Kitaro cataract training kit, and then they get oriented for the microscope on the same kit. So we do not provide wet lab, but we provide this kind. So these all things we usually complete on the first day of training. And on first day also, we just teach them how to do documentation. And we are very, very keen for the documentation. We have our own indigenous EMR and HMIS software since 30 years we are using this, and they have to fill up all the data of the patients, what they are doing. We have our own verification form before the patient enters into the operation room. And then the second day starts with the observation while the expert is operating. So usually experts are operating very fast, and they can see and they feel that cataract is very easy. But once on next day, when they go to observe the junior doctor who is operating, and they come to know cataract is not at all simply easy, but you need to go through a vigorous training. Then the second day, we just give them steps in the expert who are operating cataracts, who can deal with the complications, who have done more than 1,000 cases. So they're simply doing steps. Each step they do around 100 steps we usually allow them to do, and then really surgical training starts. Along with that, we just take the theory classes for how to minimize the complication of cataract surgeries and how to improve the surgeries on Zoom platform weekly basis. We have validation scoring, everybody knows. We have done our own proposed predictive score for visual outcome in cataract with comorbidities following small incision cataract surgeries, and we have designed our indigenous scoring system, including detailed examination. So this indigenous mathematical model to define the risk factors for the cataract surgeries. In that, score 0 to 3, we usually distribute to junior most surgeon. The score 3 to 6 to the surgeon who did more than 500 cataract surgeries, and score above 6 can be done by consultant or who have done more than 1,000 surgeries. And so this is the simple way: complete examination by primary person, scoring done by the examining person, then re-examining by the operating surgeon, reconfirm the pre-operative score what examiner has said, and then trainee rotated to all pre-operative areas. Then the surgery distribution done to each trainee according to the assessment of score, basic skill of surgeon, and definitely, as we said, it's a customization. We cannot say that you'll operate this many cases. Sometime during application, or they just ask us how many cases you give, and we say that in our institute, in 1 year, we have seen trainees who have done only 50, and in 1 year, we have seen trainees who have done more than 2,000 also. So it's totally up to you how sincere you are, but we cannot provide you the biological material. They are human beings. And then we have a system of starting with the mature cataracts. So this is the way for next day, the list for trainee is given, and they know which case they are supposed to operate. Before surgery, brainstorming done by our trainer, and then only they enter into the operation theater. Video, when they start their surgery, video live watching, as Dr. Sima already said, we have a system where we can watch everybody's video and whosoever are doing surgery, and it's not only video watching. We usually guide also, simply remote guiding also. So you can say that what the trainer is saying, no cortex cleaning from main wound, and then immediately they'll compare and they'll go to side port. So this is also a way to train them sitting at the remote places. Then they have to watch their own videos and analyze what they have done during the surgery. Watching live videos of all other cases are also made them to see, so they can learn many more techniques and many more mistakes they should not do. Video recording of all cases we have to review at any time, to review by correcting the surgeon before they repair. So if we talk about 30 to 60 days, we have a short-term training program. First day, as I said, and by the end of 7 days, we usually give them a full case under supervision, and after they perform few cases, we just tell them assistant on demand. And then they celebrate when they do their complete first case. So this is the way we just encourage them, and either it can be inside the hospital or outside the hospital. It is a culture that they celebrate whatever success they achieve. But when the trainee operate, they do complication too, and they just go crying to their room, but it is not allowed. They have to do self-analysis in our institute, and they have to report to the trainer. So this is the way they report. This is simple one case, and this is case 15 of this person. They report in this way. They send the WhatsApp message, and they send along with this sheet what they did and what they want to rectify for the next case when they do next day. And once they are doing complication, we just don't let them to go down. We have our own spiritual program. We teach them meditation, mind concentration and everything. And when they go back again, they are going back with the fresh mind. So our doctors sometimes interact with our staff also, and we have our courses who can just increase their ability and they can digest their own complication. Trainees are part of the festival of institute anyway, whether it can be a Diwali, Holi, or simple somebody's birthday. And they are part of the inauguration of all the new departments and all the new ventures what Draashti Nethralaya is doing. Exams also sometimes we conduct, and then external examiner also we call. So what we say that in Draashti Nethralaya, at least for cataract training program, we don't have age bar. You can see at any age, from any country, from any place, from government hospital, anybody can come. We just want to see this good feedback from the eye, and with the expression and the eye itself, you can see how much grateful the person is after receiving the training, and that is what we want. And they should go back and do a proper training along with the certification. So we provide certificate, and then the farewell comes and they are ready to fly. So this is the way they can fly. And once they fly and they go back to their institute, their place, they do private, they work anywhere, we just encourage them to come back to reinforce training, and again come with the challenges now again they have faced. And that is the way we do. As Dr. Sima said, It is a sandwich training program. We are also starting with Orbis International for the pediatric ophthalmology. But this way we have our own cataract sandwich program. Once they go back, they come to our institute and they are allowed to do any kind of surgeries, whatever, because we have trained them. And we are responsible for the eradication of blindness to the nation. So certain government authority talk also is required. And as Dr. Sima and every institute says, training of the trainer is also most important when you have a training institute. This is the training of the trainer by foreign delegate, international trainees and international faculties. And till now, we have trained 388 surgeons for cataract training. You can see these are the long-term and short-term training. So what are the fellowship we offer at Draashti Nethralaya? Short-term fellowship SICS for 2 months, short-term fellowship is FECO for 2 months, medical retina for 3 months, ocular trauma fellowship for 6 months, comprehensive entry segment fellowship 1 year post-MS or DNB, vitreoretinal fellowship 1 year, pediatric ophthalmology fellowship 1 year, and oculoplasty fellowship 1 year. That is the courses we offer at Draashti Nethralaya. Accommodations are offered with minimal charges. Short-term fellows are on fee basis, and long-term fellows we offer, though we are sitting in tribal area, we just give 20 to 25,000 stipend per month. And finally, what we want is happy students. Thanks to all students who made us teacher and who made us student too. Thanks to my teachers too. Thank you all. And now Dr. Mehul will tell you about once they do complication, how challenging it is to repair the complication and everything. Thanks a lot.
Thank you, ma'am.
I think I'll take few moments and stop here.
Okay, sorry. Yeah, it's already shared. Stop. It's not shared. You can share.
Yes, sir, we can see your.
So am I visible?
Yeah, visible.
Come on, which computer? Zoom call. Zoom. Full screen.
So just make it full screen, sir. Ma'am, as sir is preparing his presentation, ma'am, see the accommodation that we provide to the fellows is that campus go down, go for full screen.
Side. एक कंप्यूटर रेडी करें चेंज करें.
So it's okay. Like you can go to the next slide, press on that, and do it that way. If it is not going to go full screen, to the slides on the left side, you just go and click number 2, sir.
Am I audible now?
You are audible, but it's okay, sir. You can speak. Like you don't actually require slides, sir.
No, slides are working. Am I audible?
Yeah, you are audible.
Yeah.
Yeah.
Already
Okay.
we have done. We have done a simple study that what happened when our trainees did the complication. The objectives of study were what will be the visual outcome and what will be the epidemiology of complication during our trainee when they operate. So we have done this retrospective during 2004 and 2020, and the complication repair we repaired in the same sitting or different seating, all surgical complication, including wound construction, capsular rent, nucleus drop, IOL drop, another malposition, and other repaired complication are retrieved from our logbook. We have a documentation for trainee surgeon. They are listed, and these are the details of the logbook. They fill up the cataract sheet on online format. And these are the complication detail. Every time the complication happen, it is online logbook which they have to fill up, and they can retrieve the data in between the dates. Then we can get the number of complications which are present, which are done by any of the trainee surgeon, and trainee category also is written there. So these are the challenges. Visibility, corneal edema, comorbidities are the problem. And when there is a rent, the vitrectomy with secondary implant done in the sulcus, either PMMA lenses or three-piece foldable lenses, or if there is no capsular support, either they are suture fixated or scleral tech lenses which are indigenously designed and patented by us, which is in the market now. So this is the exactly scleral type of self-retaining lenses, scleral tuck lens, which does not require glue or does not require suture and very user-friendly, with a very small learning curve. And this is the lens placement of the scleral fixated lens. And these are the article published even in IGO with the use of these lenses. So the result what we found is our cohort involved with the 3513 complication cases out of 1,25,000 cataracts. So approximately rate was the 2.81%. And out of complication, 45% did not require any surgical intervention. They were treated with a medical treatment, and 30% I required secondary implant, and remaining people required other surgeries. And 43.9% complication reported during stage of cortical cleanup. So primary surgery in trainee category did not make significant difference in the visual outcome. So these are the stages. The wound complications were most common during the cortical cleanup with the trainees. And these are the different corrective surgeries what we performed. We performed the secondary IOL in 30% cases and scleral fixated IOL 4.4% cases, remaining lens malposition, IOL exchange, IOL explantation, cortical cleanup, and nucleus drop and IOL drop 4.7% cases. So out of total 3513 eyes, 62% regained more than 6 by 24 correctable vision. We found significant difference in case present in post-treatment vision. We studied all other variables and found that the primary surgery, either phaco or SICS or trainee category, did not make significant difference in visual outcome. We published this article, and then we published the article about secondary lens implant also. Lens malposition and comparative study of visual outcome following corrective vitrectomy, non-traumatic versus traumatic. They also found the outcome is the same. So then we have a review meeting every month with our cataract trainees. Every month we share the data of overall complication and stages at which this comparative study between residents and fellows, and with each trainee during which stage they did the complication, that we discuss that, and then in review meeting we decide what actions they will take. These are the different trainees who has performed the number of surgeries and created the complications, and then we discuss which particular step they are not comfortable with. So this is monthly meeting, and we also involve all the even short-term trainees for our research publication, and we can see that our out of our total co-authorship, 62% co-authorships were from our resident doctors. Thank you. Thank you, sir.
Thank you, sir. Thank you, ma'am. A few queries like for those ultra short-term 2-month SICS, 2-month FACO. What is the fees like?
That is 1 lakh rupees plus GST. But we give accommodation for this 2 months training. And we just don't promise the cases, but we see that every day, from second day, even they can do 1 case per day. And then later on time, they do 2 to 3, whatever are available. If they are very sincere enough and they are a good surgeon, we give them more cases also.
So, okay. So for SICS, so somebody who comes for FACO training,
Yes.
Do you make a precondition that they're good with SICS or so what any fresh MS person, can they come and apply, because they're absolutely fresh. So
Yeah.
precondition for the short-term training.
Yeah. So in this COVID time, we have seen that many trainees have not done anything. And if even they have not done any SICS, we can provide them training. We just give them 2 months training of SICS without any prerequisites. Only they should have certificate. But if they are applying for FACO, we say that the Rexis are mandatory. You have to learn Rexis. Otherwise, you will lose the case and somebody has to take away the case from you. Or you can do 1 month SICS, learn Rexis very well, be proper, you should develop your surgical technique well, and then they can switch over to FACO. So we have 3 programs, 2 months SICS, 2 months FACO, or 1 month SICS and 1 month FACO also. The charge 1 month FACO also. So that is, charges are same for everything, whatever they want.
I think it is 1 lakh plus GST, right?
1 lakh per, yes, with plus GST. And we have long-term trainees there where we do not charge. We give them stipend, 20 to 25,000 stipend.
Okay, and for the long-term trainees, the accommodation is given in the campus hospital or in the locality?
Yeah, we have accommodation in the campus available. We have mass and canteen. Everything is available with minimal charges.
Okay. Thank you, ma'am.
So sometimes it happens that once they apply and they feel that they are going to tribal institute or tribal area, but once they are stepping into the institute, they don't feel that. So first day is very difficult for them, but when they go back after 60 days, they say that we want to stay back more.
Okay, so to see how frequently do you take the short-term fellows, and
yes.
Each batch, how many do
you take? Yes. So we take our fellows every month. We do not have any customized intake. So every month we take our fellows. We see that there should not be more than 4 to 5 SICS or FACO fellows. And then we take every month and we count 2 months. Same with our long-term training. We do not have custom training. Any month they can apply, any month they can start. The training will complete after 1 year. That's all.
Okay, that's good. So what is a waiting period? Like if I apply for a fellowship long-term or this 2-month program, what is the waiting period as of now?
Yes. See, as of now, right now, we have fellows for this winter program, but this summer they can apply, and in our country everybody wants to come in summer only because they are free, but at the same time they don't get case. Still in India, people believe that in winter they want to get operated. So up to March it's already filled, but we can definitely take trainee from April. And we have 1-to-1 base interview. So we feel that this trainee needs training and they have already done many. We can take one more also. So there is no specific restrictions to us.
Dr. Vivek, just give me one minute. And see, what I found really interesting was, nothing related to cataract. You have 1 year training program for the VO fellowship. So these ophthalmologists become fully trained via surgeon within a year?
Well, yes, sir. Normally they do that because we give them very large number of hands-on training. So at least they can do minimum 40, 50 vitrectomies in a year. And they can deal with a lot of cataract surgery complication what these people are doing. So they also can be the feeders.
Yeah, wonderful. Rajesh, Rajesh, this is wonderful, right?
Yes.
We have Dr. Rajesh.
Yeah,
Rajesh,
I'll just add into that the only thing we allow our trainees who entering into our specialty training program, we allow them to do cataracts. But once they are coming from outside, they have to go through the specialty training only. Thank you so much, Dr. Sreeni, for inviting us.
Thanks a lot, sir. Thanks a lot, ma'am. It was wonderful to have you in our program. So we will move on to probably one of the best training institutions in the world, LV Prasad Institute, and Dr. Vivek Singh will be explaining everything about the training program in LVP. I mean, mostly everyone knows what happens in LVP, but see, when I was talking to Dr. Vivek, I was telling, like, though I'm from RP Center, me and Rajesh are both from RP Center. And when I was doing my junior residency, I joined for junior residency. That time, Dr. Pradeep Venkatesh was the senior resident. The senior residency rounds used to go on till 12 o'clock at night, and he used to tell us to go to the library and read till 3 a.m. and come back at 7 o'clock and do the workup and everything. But still, if you ask me, I might be scared to go and do fellowship in LV Prasad, because I mean, what I hear from people like Rajesh and everyone, it's a very demanding fellowship program in LV Prasad. So just like with Nethralaya, I had Dr. Mahesh to be there with me because he had done fellowship from Nethralaya and is one of the best retinal surgeons in India, like Dr. Rajesh, who's doing a great work, one of the best in India. He's in Al Salam Eye Hospital in Perinamana and Calicut. So after you speak, and Rajesh can explain his experience in LV Prasad Eye Institute. Dr. Vivek Singh is a phaco refractive surgeon, and is one of the best in LV Prasad Eye Institute. And thank you, sir, for giving us your time to participate in this program. Please take over.
Thank you, Dr. Sreeni. It's pleasure is all mine. Thank you for having all of us here together. So I believe I'm audible very clearly, and my slides are visible too.
Absolutely.
Yes. So I would, at the outset, like to thank you again and the KSOS for having all of us together here. Being a part of a bigger institute is a privilege, but again, it's a responsibility too, to ensure we give equitable care, distribution of proper knowledge to everyone alike. And we have a larger responsibility of handling and taking care of the nation's load of blindness. So congratulations to all the previous speakers for doing such fantastic work. What I'm going to do in the next 20 minutes is I'm not going to be very elaborative. I'm just going to be very brief of the work that we do here at LVPEI. And so when a resident does, go ahead with the residency program in our country, the residency program in our country is not in a very great shape. And if you compare with the Western residency program, not many residency programs do give basic cataract surgery, for that matter, and be an SICS as well. And there's a subsequent need which is felt, and that is a fellowship. So if you ask a resident, how do they join a residency program, or how do they decide about a residency program? The first question that they would tell you about the surgical numbers. Well, that number doesn't change when they apply for fellowship as well. The question does not change, and the question remains the same. What is the surgical number in a particular institute that is being provided? And as rightly reiterated, by multiple speakers, that it's not the number that matters, but how you do it and how the foundation is laid for that first few cases that matters. So at the outset, I would like to tell that I don't have any financial disclosure, and I'll just brief up the cataract training program that we have here. And it encompasses the following fellowship programs that we have, starting with the long-term fellowship programs. Then we have a short-term fellowship options as well. And then there are certain virtual trainings that people who do not want to come here, travel here for fellowship programs, how they can be trained in cataract. And then there are various other training programs, lecture series that we at LVPEI run so that people outside can benefit as well. This is for trainees as well as private practitioners. So earlier, before COVID, this was in fact, even before the COVID started, our fellowship program included 2 years of, so each of the specialty, individual specialty used to be of 2 years. So cornea 2 years, glaucoma 2 years, retina 2 years, cataract and refractive was for 15 months, pediatric 2 years, plastic 2 years. But one fellowship that stood out was a comprehensive fellowship, and that was for 3 years. So earlier, before 2020, the cataract training was provided to all the entry segment surgeons, the cornea, the glaucoma, the cataract refractive, as well as the comprehensive fellowship people. It was not provided for retina, pediatric ophthalmology, as well as plastic. After 2020, the entire fellowship program was converted to a comprehensive module, which was a 3-year program. And all the trainees that were included in this fellowship program had to be trained for cataract surgery. Now, what is this 3-year comprehensive program? We'll just go through the entire detail of this 3-year comprehensive program. I'd like just to take you through a life of a normal comprehensive fellow. So once selected, now the selection process happens twice a year. First January, there's a January batch, there's a July batch, and these are the 4 campuses that they are being selected at. The Hyderabad, Bhubaneswar, Visakhapatnam, and Vijayawada. So once selected, the candidates would be allotted each of the centers and various other specialties. And once they join, the comprehensive fellowship is divided into 3 basic steps. So the first 9 months is a comprehensive rotation in each of the specialty. It starts with an induction and also involves a very meticulous cataract training program. The subsequent 12 months is a secondary center posting where the trainees, they go to a secondary center. So we do not indulge in camp-based training. We go locally, and we have set up our secondary centers to meet the demand of the villages and the rural areas. So a trainee gets to spend 12 months a year in a secondary center, and then subsequently they come back and join the subspecialty that they have chosen for 15 months. So life in LVPEI is very popular. It starts quite early, starts at 7, and you can't be late than that. The door closes sharp at 6:59, and that is when your classes start, and you have your regular lectures, which are being taken by the faculties and presented by the fellows themselves. The lectures series now that are being run for the fellows or for the trainees for the first 6 months are a bit different module. It's called as an active learning process, where each of these specialty are being run for 1 week, and each of the specialty are repeated after 6 weeks. So if a cataract module or capsule is being run for 6 days, after 6 weeks, again, a cataract capsule will come. And in this active learning process, we concentrate on very basics of each of the specialty, as basic as slit lamp examination techniques. So we were talking about the foundation. The foundation is laid in the early morning classes here. Now let's talk about the individual or the split that each of the fellow goes through. First 9 months, what happens with these trainees in the first 9 months? First 9 months, I'll just talk pertaining to cataract. The induction starts first. And then what do we do? How do we take a trainee to ensure that they become a good cataract surgeon by the end of 9 months, so that they become, or they go, or they travel to the secondary center as a safe cataract surgeon, so that they can independently operate on the patients. So After the morning class, we do have again small group discussions where we go back to the basics, discuss very simple steps of the cataract surgery. This happens for all the trainees who are being posted that day for a training hour. So we have a specific team, dedicated team of trainers, and we have a dedicated team of optometrists who are involved in training, and their job for that particular day is only train people. No other allied jobs. They do not have clinical duties on those days, and the job is only to train people. And we have one faculty consultant, faculty who is free each of these days and ensures that the training is delivered. So we discuss about various basic steps to begin with, and then once this is done, we have our own portal where we have a lot of videos which are being saved. We ask our trainees to undergo, observe these videos and go through all of these videos before they begin with the actual grind. And we also ask them, this is a module that is free for everyone. So all the institute, everyone who is sitting in any corner of the world can log into CyberSight, and they can undergo these two very fundamental tests which are being conducted by CyberSight. They are absolutely free, and they also give you a certification. So we ask the trainees once before they, this is something that can be done once they are done with the clinical duty at the end of the day at the comfort of their room. So this is something which we ask them to complete before they join or they start with the cataract training. So watching the video helps them improve their observational skills, and this is just to ensure that they are reading as well. Then we take them through the wet lab courses. The wet lab courses are again very meticulous, and unless and until a candidate does a particular number of suturings or tunneling or capsulorhexis on the wet lab, they are not promoted for live surgical training. So this is a typical scene from a wet lab where a trainer is training all the trainees when they have joined, when they have been scheduled for a training in a particular month. And as you can see, we have a state-of-the-art wet lab training, and here the surgeon, the trainee is performing, trying to perform a capsulorhexis from a controlled capsulorhexis in a dedicated area. This is nothing but an IOL box that she's trying to make the rhexis at. And I'm sure people come up with a lot of innovative ways and techniques to teach different, steps of surgery. And here we do advise, we do take them to tunnel making on goat's eye. And this is very commonly used for learning tunnel as well as doing rhexis and suturing practice. So here you can see people practicing suturing and a lot of sutures that have been, so we are advise the trainees to construct a tunnel and take sutures on the same tunnel. You can see, you can make out there's a rhexis which is being nicely constructed around perfect capsulorhexis, which is achieved in this goat eye. And once that is done, just in case if there is non-availability of the goat's eye, sometimes there are scarcities, we come up with certain other things. And I'm sure, like I said, people do come up with certain innovative things to do other steps. So this is a tomato, which is a very good medium for performing a tunnel construction. So this is something that we do again. And suturing can be again practiced on the suture foam itself. And this is something that is being done by the trainee here. Once that is done, once the wet lab is done, and after the observational skills, observing certain videos on the sonic platform that we have, as well as the CyberSight, the next step that we involve our trainees at is a simulator. And we have a collaboration with Help Me See from Mumbai. And we have a couple of simulators, and the simulator training program, the roster is planned before, again, these trainees can go and touch patients' eyes. And this is an SIC simulator. And as you can see, they are being actively trained here by a trainer. We have a dedicated simulator, a faculty who is posted every single day. So we have a dedicated simulator trainer, and we have a dedicated main OR trainer who are present on every single day. So the advantage of simulator are multiple, and this has been described earlier as well. So I'll just take you through this small video. As you can see, one advantage that I feel apart from doing the same step multiple times as well as monitoring and assessment is you can actually see the candidates' hand movements and the way they are holding the instrument. So this is something which is taken on a TV, which is being where the video has been projected. So you can actually see how the instruments are being held by the trainees, and you can just rectify that as well. So this is something that we prepare the trainees with before the actual grind. The two steps that are different in the simulator that we do differently is, so we perform the Blumenthal technique, and we do not use the Vectis as such, and we do not use the Simco as a part of the which is as a part of the simulator training. We do use the AC maintainer with a single port, and we do the Blumenthal technique for the delivery of the lens as well. However, we do not shy away from learning different techniques, and we advocate that for our trainees as well. The simulator has come up with the complication module as well of late. So we have the ACIL insertion, the CTR placement, as well as management of small pupil with sphincterotomies. And very recently, they have come with the suturing module as well. So all of these are being incorporated in the training process before the surgical training actually starts. What they're going to come up with is in the next few months is phaco module as well, and management of posterior capsular rent as well. So probably when that comes, we are going to incorporate that as well. So let's come to the real test. The real test is the training OR, where the live surgical training happens. So we divide the trainees for SICS training first, and they are being trained for SICS training. Once they are comfortable with the SICS training, they move on to the next step, which is the phaco training. And before the phaco training, they actually get to perform a lot of SICS independently in the fellow OR. So we have two dedicated ORs for them. One is the training OR, and one is the fellow OR, where the fellow OR operates the cases immediately, independently. And SICS training is where we have, like I said, the training OR is a place where we have a dedicated trainer present every single day. So once the SICS training is done, the training proceeds with the phaco training. And once they're comfortable with each of these, they go and operate independently in the fellow OR. There are ways of assessment that has been placed. Video reviews happens with the trainer and as well as the mentor. I'll just show you the assessment. We'll discuss about the assessment later. So this is a typical scene from the training OR. We have live video recording as well. And the trainees, the initial few days, we do concentrate on the ergonomic, a lot of ergonomics, starting from the posture of the trainees that they operate, and we have the posture as well as the like Dr. Smita pointed out, we do orthoptics workup of each of these trainings before they start or begin the training ORs. We do teach them a lot of other part of the training that is related to cataract, like setting up the trolley and putting up their own, setting up their own phaco machines, draping their own patients. We do also teach them scrubbing and draping before they start actual training cases. They also spend time in sterilization unit to understand about the sterilization process before they actually begin with all of these surgical cases. So we have very active Alcon PDP training, which and through the help of the LVPEI faculties, we run a lot of lecture series for all of the trainees. And that ranges from basic phaco-dynamics to complication management. The Alcon PDP training also helps us with the foot pedal control before each of these trainings starts with the phacoemulsification. And they also follow all our trainees when they are to the when they proceed to the fellow OR, or when they progress to the secondary centers. So assessment, like have been described previously, we do follow the similar the Oscar training for SICS as well as phaco. What we have done very recently is, we don't have an app, but what we have done very recently is we have converted this Oscar training into a small Google form. As you can see here, this is a part of the Google form. And what we have additionally included in the Oscar, in the Google form, is complications, presence of or absence of any complication that the trainee encountered on a particular day. So this directly comes and get registered with the Excel sheet that is being maintained by the cataract team that we have. And this is something that is being followed up as the time progresses. The how many cases does a trainee operate in the first 9 months? So the number varies, and we usually follow an equitable distribution rather than equal cases. So someone who is who has done a lot of cases, we categorize all the surgeons, and someone who has done lesser cases, we try to give them more cases, so that there's an equitable care rather than equal cases that are being distributed. So all the cases, the patients that are being posted for training OR as well as fellow OR are categorized. So patients who are category 1 are being, these are based on the risk gradings of the cataract as well as systemic. Patients who have a risk grading of 1 are being operated in training OR, and in patients who have a risk grading of 2 or above are being operated in the fellow OR. Likewise, we have grading for the trainees as well. So we have category 1 surgeon, category 2 surgeon, and category 3 surgeon. All this track record has been, is being maintained by the cataract team that we have, and we categorize each of the surgeons on monthly basis and give this data to our team, patient care team, who plans for the distribution of the cases for each of the trainees in the fellow OR. So this was about the first 9 months, where the induction is done, a comprehensive and meticulous cataract training is done, and each of these trainees learn other aspects of a comprehensive eye care by rotating in other departments as well. Once this is done, they go and spend 1 year in the secondary center, which is, I believe, is a game changer. This is a place where they learn a lot of values and principles and disciplines that LVPEI stands for. Here they become from a surgeon to a doctor, and this is a place where they actually learn advocacy and try to become an administrator as well. So we have at present 22 secondary centers, and this is an ever expanding. Since the time I had joined LVPEI, it's ever expanding, and it continues to expand. And we operate a lot of patients there. So there's the data there. The outpatient services that have been given to 3.43 million, and surgeries have been 371,000 surgeries have been performed till date. And majority of these patients surgeries have been performed on the non-paying patients. So how many surgeries does trainee gets in their secondary center posting? Probably anywhere ranging from 500 to 2,000, depending on the centers that they're posted and depending on the capability that these surgeons can handle, a trainee can handle. For the variety of cases, so cataract, pterygium, DCT, DCR, chalazion, and corneal tear repair are the commonly done cases. However, there are certain secondary centers where specialty fellows under a supervision of a faculty, we have a faculty visit as well to each of the secondary centers, can perform other specialty surgeries as well, like trabeculectomy and lamellar surgeries as well as squint surgery. So we do have a GA set up in some of our secondary centers as well. The final 15 months is again when the trainee joins the subspecialty. However, the cataract training does not end here, and I believe there's no better way to learn than teach. So when the trainees join, they are given we ensure that we give them a trainer, we make them as a trainer as well, and we give them a training OR where they try to teach cataract surgeries to the new joinees. And this is again being monitored, and we take frequent reviews from the trainees as well as the staff, whether the trainer is doing well or not. And this is, again, like I said, being monitored irrespective of the specialty that the trainee joins. They have to continue with the training process as well. And but then if you might just think, what is different for a cataract fellow who joins, a cataract and refractive fellow who joins, what's extra in that is there for a cataract fellow, because cataract is being learned by everyone. So once the cataract fellow comes to a final year, they start learning the art of identifying patients where they would implant the premium IOLs, the toric IOLs, as well as the multifocal IOLs. We give them surgeries, the premium IOL surgeries as well. They do involve themselves actively in planning for flax, and they do get hands-on as well. They get to learn a lot of innovative device and high-end devices like Varion as well as Callisto. And as a part of the refractive surgery, they do get to perform a lot of refractive surgeries as well. So this was about the long-term training. About the short-term training, we do have an SICS training program and a FACO training program for externals. This runs primarily in January, February, as well as June and July. And across, this is open for all the campuses that we discussed earlier: Hyderabad, Vijayawada, Bhubaneswar, as well as Vizag. And they get about 20 to 40 cases during this term. And like discussed earlier, it's not about the numbers, but the foundation that is being laid during this initial the initial training month that matters most. We do not discriminate between the short-term training as well as the long-term training. The same principle, that is all the same training process that are being followed for the long-term are being followed for the short-term trainees as well. So we do have our standalone simulator-based training as well. So any trainees who are interested in enrolling themselves for a simulator-based training, we are open to them as well. This simulator training runs again on a weekly basis, and we involve 4 trainees at a time per week. And we do involve, like I discussed about the virtual training, we do have a virtual cataract and refractive series. We already completed a year of this series, and this happens every Tuesday, and this is open for all the external as well. And anyone can enroll for this cataract and refractive series. This happens every Tuesday from 6:30 to 7:30 p.m. And if just in case you're busy, you're not able to access these classes live, you can always go back and see all the recorded videos. Even if you join them today, you will have access to all the videos that have been, or all the classes that have been presented in the last 1 year. Apart from the virtual training, we do have a fixed training program for all the cataract trainings, all the cataract performing surgeons in the in-house. And this starts from iStart. So iStart is where we train them for various, this is something that we begin the training with. This all the surgeons, they learn very basic steps of scleral suturing, corneal suturing, as well as handling a microscope. Then we have a reload where this runs for primarily surgeons who are a bit experienced, and this is something that deals with complication management module. This is in collaboration with Chitrakut Eye Care Center. And then we have our astigmatism management program, yearly and astigmatism management program, which happens where we deal with primarily, we teach people primarily toric IOL surgeries. And then we have an annual training the trainer, where we ensure that we deliver or teach how to train the future generation of trainers as well. So as already discussed, who's a good surgeon? A good surgeon is not one who has a good hands, but also a good knowledge about what a surgeon is doing, who has a good, who empathizes with his patients, has a good hand, and also at the same time remains humble even after achieving good number of surgeries. So we do have fun. Apart from the usual belief that people have that we are very strict, we do go out and we take our trainees out as well. And at the end, they all have their, done their farewell caps, and they all have their smiles on their faces at the end of the fellowship, knowing that they are ready to face the outside world with a lot of confidence. And I would just like to acknowledge my team, Cataract team, who works very meticulously and very hard to ensure to deliver one of the best training to all the people, all the trainees that join our institute. Thank you so much.
Thank you, Dr. Vivek. You just showed why LVPEI is one of the best training institutes in the world. I mean, you just mentioned the 4 H's. So probably like when Dr. Mehul was presenting, when we discussed the hand skill is probably a bit overrated for a phaco surgeon, because you don't need quite a lot of because it's what is there is up here, the decision making, the planning. So when not to do something, when to do something, and that is where the basic training comes in, and that's where LVPEI and Nethralaya and all score. Congratulations, you've been doing a wonderful job. And just in case this, importantly, like what is a stipend for the comprehensive?
So it's it's 25,000 when they join, and when they are in the final year, it becomes 30,000. So it's more or less the same that most of the fellowship training program would have.
They don't get time to spend even a bit of that, right? So what time they start at 7 o'clock? What time do they get free?
So it depends on the fellowship program that they have chosen. Usually the cornea and the retina OR and clinics run longer. It gets done anywhere between 7 to 10. The OR runs even longer, and rest of the specialty anywhere between 6 to 7, 6 to 8.
So do you have a requirement for the fellows to publish papers?
Yes. So there are 10 arms of or 10 principles that the LVPEI actually runs on, and so research is very integral component, and we encourage research in each and every aspects. So right now we are working a lot on training related research as well. So all these candidates, so we encourage them for presentations, both regional, national, as well as international as well. So like, research is very much integral part of the LVPEI training part, training, cataract training.
So do you give them support for the travel for national and international conferences and all?
International, we do not give them support for the travel expenses. Registration, yes.
Okay, Rajesh. And he's an LVPEI alumni. So what has changed from the time you were there? Yeah, you had a pure retina fellowship.
Yes. So I actually did my retina fellowship in 2005, 2006. So there was no specifically fellowship specifically dedicated to cataract and refractive surgery at that time. We had only retina, cornea, pediatric, plastic, and then comprehensive fellowship. So now the major change that has happened is that most of all the fellows are now considered as comprehensive fellows. So that is in one way very good. In another way, it makes the fellowship program a pretty long one, because as Sreeni was telling in one of the previous presentations, because most of these people who join for the fellowship, they have done their MBBS, they have toiled years for getting a PG seat. Then after the PG seat, they're going for a fellowship. So they want to settle in a life. But when it goes for a long 3 years, sometimes it becomes difficult for some of these fellows. And even 25,000 stipend appears to be pretty decent. But that is something that is going to trouble many of those people who join the fellowship. Other than that, the fellowship program is the best. I think they stick to the best facility or the resources that are available. and they use the cutting edge technology, and also they also get an idea about how to do research and publish papers. So that is the advantage of doing a fellowship in LVP. And again, the concept-based training, the concept that you get in LVP, at least from I cannot comment on the cataract side, but at least from the retina side, the concepts that you get from the LVP training is very different from what in other institutes. Maybe I have had exposure of working in RP Center also, but the major difference that I found between LVP and RP Center was that the concept-based training is much more in LVP. And again, the training is very structured. You cannot do surgeries just by yourself. You are always under supervised, and you get a step-based training until you become confident you will not be doing surgeries independently. And then you start doing surgeries independently. You get fairly good surgical opportunities in LVP. So these things are, I think these things are still there in LVP from what I've seen from his presentation. But the major difference is that the entire fellowship program has been changed into a comprehensive fellowship. What I would like to find out is that, yes.
Yeah, like if you were trained in cataract surgery, like see, being a retinal surgeon is a job on its own. Like, see, you have a combined surgery because Prakash is a retinal surgeon who can do wonderful phaco surgery, but he is really concentrating on retinal surgeries only. So, if you want to be a real retinal surgeon, you do. Does it really help to have this 1 year cataract training, because you have a great number of cataract surgeons to help you? I mean, mostly you are. I mean, if you are a retinal surgeon, you're going to be in an institute, and you'll have cataract surgeons like me to take care of how many number cataracts that you have. So, is it really adding on to the value of the fellow who is coming out of LV Prasad, LVPEI? Like, is it? What do you think?
If you know cataract, definitely it is an advantage. I'm not saying that if you do know retina, you should not be doing cataract. It can do cataract. That is definitely an advantage. You can tackle your cataract cases. Most of the people require cataract surgeries also sometimes. If you are working in an institute where you have other surgeons who can tackle the cataract surgery, then that is fine and good. But if you are going for an independent practice after some time, then you may have to do cataract also at that time. But the problem is that what our teachers used to tell us, because I was trained under Dr. T.P. Das. So he never used to allow us to do cataract surgery or even watch cataract surgery. So the main reason was that if you go for cataract surgeries, you will be the kind of results that you get from cataract surgery, you are not going to get from retina surgery.
The money that
so
you get.
There have been situations where trained retina surgeons have moved away entirely from the retina specialty and have concentrated only on cataract surgeries. So that is something that can happen. But on the other hand, if you know both surgeries, it is well.
There are also two ways to look at it. One is the transition as a retina surgeon becomes very easy once you're very well trained in cataract surgeon. Your hands are very stable, so the transition becomes easier. Training a retinal surgeon would be much more easier once they're a good cataract surgeon. So that is one.
Yes, definitely. If you have not done enough surgery during your residency, that is during a PG days, then this gives you a pretty long, a good time to get adjusted to the microscope, develop your hand skills and all those things. This definitely helps.
And the second advantage is, a lot of things have been said about COVID. A lot of people have had very little exposure in cataract, and this is going to continue for the next few batches as well. So the cataract exposure has been very less. So they get a lot of cataracts to do. Secondly, they get a choice of their specialty. So now a cornea person anyways would be doing cataract. But the most advantage that I see here is for retina fellows or plastic fellows or pediatric fellows or glaucoma fellows. They do a lot of things, for example, a cornea specialist would anyways do a cataract. But for someone who's in a retina specialist and wants to go back and start a private practice, it would be very advantageous. For a pediatric, for an oculoplasty, it is going to be, a lot of advantages. So there are various, different ways to look at it. And what we are trying to do here right now is trying to make them comprehensive, because a lot of time, a lot of basic skill sets are lacking. Basic skill set, when I say about basic skill set, the basic slit lamp examination techniques are not proper. So once they come here, the fellowship program, the initial 9 months, they learn a lot of basic techniques like gonioscopy or slit lamp examination or 90D or 20D evaluation that they might not have got an opportunity to work or do when they were a resident.
Yeah, that's wonderful. Arulmozhi Varman, sir. See, sir,
Yes,
sir,
yeah.
sir is probably one of the best surgeons in the world. Sir, so what is your opinion? Like, they're having this comprehensive.
The same thing that Rajesh said. I feel tying down somebody for 3 full years really eats into their lifetime. I kind of feel strongly about that. I'm not criticizing any organization or institution that are doing it. It's their experience and their thought process that they're doing. They're doing it brilliantly. Absolutely. Somebody who comes out of LVP, the level of experience is different. But I feel that, after doing 3 years of MS or MD, and then coming back and whole 3 years tying down into one subspecialty, I feel that is a bit of a pressure on the person, on time constraint itself. So I believe in doing a 1-year course. We'll talk about it in my talk.
Okay, and you probably should have some rich parents to take care of you. I mean, it's a real issue there. Like, see, you do a MD in RP Center now. It's I think the stipend is 1 lakh plus, and you come down to 25,000. I mean, I know that you don't get time to spend that even, but still, see, that is something that is I don't know, like it is not a forum.
Can I just say one last comment?
Yeah.
So how the mentality now of the trainees is, and how the education system is progressing nowadays is. So when we are doing MBBS, half of the skill set, for example, if I have to learn ophthalmology, half of the skill set, my mindset is such that, and this is not, a trainee's fault. This is the system fault, that my mindset is such that this I learn during my specialization. When I'm doing a specialization, say MD or an MS, okay, I just concentrate on the basic thing. This I'll leave for a super specialization or a fellowship. So we just keep, pushing that thing. And the idea is, when do we stop this? We can have multiple fellowship, but where is the end? So we need to have a program. If the residency program is so well structured, then we don't need a fellowship program. Okay, so then probably a need of 1-year fellowship program is good enough. So there are a lot of insights to this, a lot of development, a lot of progress that we can make in this. And like I said, being a part of a big institute is not just a privilege, but it's a responsibility that all of us have to take. So that is this discussion is always going to be open for debate.
See, this is, I mean, just 1 second, sir, like, this is something that I asked Dr. Tushar from RP Center. He's in charge of the training, whole training programs. See, I asked him, I mean, I'm asking you the same thing. Like, see, the RP Center is the Apex Institute for Ophthalmology in India. You are the up there. See, if you consider as you rightly said, the MD, MS programs across India, probably less than 10% of these kids are properly trained by the time they come out. That's statistics. So, isn't the responsibility of these big institutes to make sure that the teachers there are trained? So you have a training program for them. See, you get the finished product, the kids out and train. So if that the training program there is perfect, you said you've increased to 3 years because I mean nothing is happening during the MDMS. So I mean, shouldn't that also be part of the responsibility of the bigger institutions to make sure that these medical colleges do give proper training for these kids? So it's just a thought.
Yeah, very correctly. So, but then what bigger institutions can do is lay foundation, have training programs, collaborate with the regional institutes and train the trainees from there. So that is what we are doing also here. We do have certain programs here in-house where we allow the external government students to come for a month and for an observership, and to be trained in clinical skills rather than surgical skills, in clinical skills. So then
I'm not talking about the students, I'm talking about the teachers there.
Yeah.
So that is
that can be done through various programs, again, like training the trainer. And this is again important. And like I said, respect institutes and all of us need to come together to plan such modules where, probably we just train the trainers who are involved in training.
Yeah, the mindset of the teachers that has to be changed, and you people have a huge responsibility. And I think
a lot of logistics involved. So even if you try to change the mindset, even if you train the trainers, once they go back, there are a lot of logistic issues, having a training OR or having cases, having simple instruments, lack of devices. So a lot of logistic issues that these people might be facing, even if they have opportunity or that zeal to train. So a lot of challenges, but then let's not discuss about the challenges unless and until because there are challenges, we have a lot of opportunities as well to excel and work on them.
Thanks a lot, Dr. Vivek. Like, it is wonderful to listen to whatever LV Prasad Eye Institute is doing, and thanks, Rajesh, for sharing your experience and sharing your comments. And sir, Dr. Arulmozhi Varman, as I said, probably he's a surgeon we are always looking up to, and see, one phone call he picked up, and I didn't really know that he knew me, but he said Sreeni, and I just asked him, sir, can you make a presentation on the training program in your institute? He was very happy, and he was traveling. He was in Bangalore, and thank you, sir, for sparing your time for our program. Sir, please start, sir.
My pleasure, Sreeni. Absolutely. We do phaco training in my clinic. We've been doing it for the last about 20 odd years, and I wouldn't call it phaco training alone. You should call it a general ophthalmology fellowship, which is limited to 1 year. So we take 4 full-time fellows every year. It's a 1-year duration. During this period, the post-COVID and the COVID period, the number of surgeries they do is dropped down to between 100 and 120. Normally, it's 150 surgeries at least per candidate in 1 year. They get very good exposure on glaucoma from the diagnosis and using all the instruments like OCT or ORA and anything else. And medical retina, they're exposed and they get to do PRPs and barrages. They do a reasonably good number of LASIK, usually about 6 to 8 eyes, PRK, just 2 eyes. They get exposure on SMILE also during this period. So when they finish up 1 year, they are completely ready to go anywhere and start their practice or get into a corporate hospital or into any other institution at a junior consultant level very comfortably. That's our aim. So during this period that they are here with us, their working time starts usually about 8:39, depending on whether they are going for the outreach programs. We do about 4 to 5 outreach programs every week, which drastically came down during the COVID period. And that's why the number of surgeries also went down for the fellows. And that during the COVID period also, we cut down the fellows to only 2 because we didn't have much work. Now we have 4, that's the usual number. So they have to attend to the camps on rotation. They have to be on the OP morning to evening, and they have to come in and observe all the consultants doing all the surgeries on turns, because somebody is in the OP, other person should be in the OT seeing surgeries, whatever is being done, whether it's oculoplasty or squint or refractive or VR, glaucoma, cataracts. They have to be there. A fellow, 1 or 2 fellows will be there observing and learning with that. And all the surgeries that they do, of course, in the beginning, there's a basic training we look at. We find that most of them are reasonably good on a slit lamp and indirect by the time they come here. Of course, they're very poor in refraction. We are very particular that they learn refraction. right from the beginning to the end with streak retinoscopy in the first 1 month. So they get to be good refractive surgeons. We do take several short-term fellows from as low as 1 week to 6 weeks. And these are fellows where they pay us. The fee is charged. As far the fellows who stay with us for 1 year, the first 3 months they get 20,000. Second 3 months they get 25,000. The third 3 months they get 30,000. The third 6 months they get 30,000. So it's a one-on-one training session once the person is in the OT. They encourage to go and assist and observe all the other subspecialties like oculoplasty, squint, and even ask and take chances on assisting. But they wouldn't get too much personal experience in those subspecialties. As far as cataract is concerned, we stick to only phaco. We do not train people on SICS. It's a one-on-one training continuously. From the beginning to the end, there would be somebody with them. And as they get experience, the senior surgeon may come out and leave a more less senior person in place again. Nobody is away, left alone at any point of time. All surgeries, including the ones done by the consultants, are all recorded. Any of the surgeon, the trainee can go back and look at any surgery they choose to. All trainees are in, we insist that they buy a 1 or 2 TB hard disk when they come and join us, and their individual surgeries are permanently recorded and given to them. And during the evening, when there's free time, they can come to the consultant and play that day's surgery and ask for opinion or ask for correction, ask for any other advice that they would get from the senior consultants. The surgical library is maintained permanently. All surgeons, it's available for them anytime at all. The main thing that we have changed in the last 2 years is all the surgeries are with the RTO 3D system. Right? It's kind of unbelievable that off the bat, we handle quite a few number of fellows who come to us from the private medical colleges where they have almost zero surgical experience. They have not done a single cataract. They may have done a few chalazion and maybe 1 or 2 pterygium, and hardly ever have they done anything with cataract. We're talking about dealing with such raw hands. From day one, we start them on the 3D, and the results are, mind-boggling. That's the only word that I can use. I'll show you the workup that we've done. So we've done a study, we've been using it for the last 2 years. So comparing the learning curve of cataract surgery trainees with the regular microscope and with the 3D. So we've done this, and we looked at the speed of learning, rate of complication, postoperative visual outcomes. The scoring this time system was devised using the ICO scoring pattern, Oscar, and the scoring was 1 to 5 depending on the level of skill. The rate at which the trainee reached maximum scoring was documented at the end of 100 cases, and this score was analyzed between the microscope versus 3D microscope system. So all the fellows who were with us 2 years before were on the regular microscope, so that's a retrospective. And everybody now is on 3D, so that part is kind of prospective. They're comparing a retrospective with a prospective. And all trainees will monitor a single competent surgeon and cases taken over in the case of complications. The slightest complication, they would stop, take it over, or any difficulty that the trainee is experiencing, the experienced person would take over, finish that step and give it back to the person. Or if it is too far gone, take over and complete the surgery. So what did we find? To learn the proper incision, the paracentesis, doing a clear temporal clear corneal incision, we found that the microscope group needed about 17 odd procedures before they got it right without making a mistake. The 3D, they could get it in 10 cases. Capsulorhexis, this commencement, that it took about 12 cases before they could, and I have to put in a word here, we don't do any animal studies, we don't do any other model eye or anything. All of them are trained directly on the human eye. So the commencement, it took about 12 cases before they got it right, while the 3D, they got it right in about 9 cases. The completion, doing the full capsulorhexis, the difference is very, very significant there. Where on the regular microscope, they took about 14 surgeries before they could do a good complete capsulorhexis without the senior consultant intervening, taking it over and doing it, or it was run out or lost. We found that that was less than half, about little less than 6 cases, they could do that. Cortical cleaving hydrodissection, as we thought, no great difference between the two. When it came to the phacoemulsification probe and second instrument insertion into the eye, we all see the trainees trying to, get the chopper through the side port and struggling, or trying to get it through the phaco tip or the phaco needle through the main port, and they're struggling to get it in. We found that where it took about 8 cases at least before they were comfortable, this was achieved in about less than 4 cases. The stability of the second instrument inside the eye was again very, very different. About only half the number, 10, and there was less than 6. Nuclear sculpting, again, it was unbelievable that half the number, only they took about 8 cases before they could understand what was depth and how deep they should go, when they should stop, where the surgeon had to stop, take over, and show it to them. Here they could achieve that skill in just 4 cases. Nucleus rotation took about little less again, 9 for rotation. Here it was only 5. Nucleus cracking, not much of difference. It was about 7 cases. Here it was about 6 cases. That again is expected, because once the trench is made properly, cracking is no big issue. Wound distortion. We found that they were distorting the wound, holding the probes in a odd way where the wound was distorted. That was significantly lesser with the 3D. Positioning the eye centrally. Always we had the trainees pushing the eye down, pushing the eye away, turning the eye down. That was much lesser, but the difference was not too much. Intraocular spatial awareness, the awareness of where the instrument was inside the eye, was significantly better with the 3D. Atraumatic iris handling, again, was much better. Average speed of completion of cases where they were able to do within about 18, we are talking about only the phaco part, not the, getting the eye draped and getting ready and starting, just the phaco. Once the phaco tip is inside the eye, till they complete it, the time taken, if you take it as at least 16 minutes, 17 minutes, we found where it took at least 16 or 17 eyes before they could get to that skill set. Here it was only about 12. And then we come to transition to topical anesthesia. By the time they finished with the first 3 months, they were on to topical anesthesia. Here you found that they had to do at least 20 cases to get on the microscope to get a topical, and they could do it in 10, half the number. Individual competency to complete a case from start to finish without the consultant stopping and taking it over took about 20 cases in the microscope. Here it is done in half the number. Again, that was really mind-boggling. And visual recovery was about the same. There's no great change there. The rate of complications, out of 100 cases, we found that there were some complication or the other. It could be a drop, it could be a PCR, it could be zonular dialysis, iris chaffing. All of these came as complications. There were about 27 cases out of 100 cases. Well, that's dropped down by almost half, 14 cases out of the first 100. So all this has made a big difference to our training program. So every person off the bat goes on straight away onto this. And that's something that we were thinking that they would find difficult. No, they don't find it difficult at all. It's extremely gratifying to see the way that these youngsters can pick it up at no thing. The question to be answered is, once somebody is trained on the 3D, one asks whether they will not find it difficult to go back to the regular microscope. Not at all. I've been doing phaco for 30 years. I do 3D, I find my skill improves. And I go to the microscope, I'm doing much better. If that can do to a 30-year experienced surgeon, imagine what it can do to a novice beginner. And that's something that surprised me to the core, where I thought that my skills are plateauing. I can see definitive improvement in my skills just by doing 3D and then going back to the microscope. It doesn't drop 1%, it actually makes me a better surgeon on the regular microscope. This is a regular setup in our OT, where now this the consultant is taken over to help out the person there. I'm going to play, this is a surgery done by a person who's been with us for just 2 months. This is the 18th surgery that this fellow is doing. Absolutely no surgical exposure whatsoever during the residency, 0. The total time taken from the beginning to the end is about 28 minutes. That is from the start till the IOL was put in, but the surgery alone took only about 16 minutes. So I'll just keep fast forwarding. It'll be too long to go. So this is where this capsulorhexis is being done. So please remember, this is only the 18th case that this trainee is doing. An absolutely raw hand who has never done any cataract surgery at all before. And the red glow that you get out from the 3D instrument is always misleading. This is a kind of, it's almost a grade 3 to grade 4 cataract. We'll know that as we go ahead with the trenching. So you'll find that this, the trainee is very slow, but very sure, no difficulties. Will finish the rhexis very comfortably. Since the chamber was shallowing, the surgeon has come out, gone back in now. This is one of the steps that they find most difficult, is to re-enter each time comfortably. You find that this is completed. With good spatial orientation and skill. We come back at the beginning. So hydrodissection is done. You find now as the trenching goes on, this is a very hard cataract. It's not a soft cataract at all. And the surgeon is very sure about the depth. The configuration of the trench is almost perfect. The crack I left out. Yes, we'll just go to the cracking. See the skill in the cracking done effortlessly again in the hard cataract. For somebody who's experience of only 2 months, rotation also is good. And this whole surgery was done without the trainer having to stop, take over, do anything. Of course, they were guiding the trainee from by verbal commands, but absolutely no taking over. Start to finish was completed. Well, I'll show you the chopping also. If the person is a novice, it's very clear the fear which they will be. But the chopping. Gets a good chop. And you can see right through, there's no distortion of the wound, there's no leak, no chamber collapse. Extremely good control. Positioning of the pieces in the right place, holding it properly. And so up to this time, it's taken 18 minutes, start from the beginning. So we'll skip on, move on. So actually to conclude, 1 year is good enough. About 100 to 150 surgeries, if the person does with proper training, is good enough to become a good phacosurgeon. At the end of 1 year, these people are on to 100%. By the way, this was topical. Though it's only the 18th surgery, it was done on the topical by this training. So about 150 surgeries, if they can do with proper training aids, one can become a very good phacosurgeon where they can go and survive anywhere. By the time they finish, they would have put in hooks, they would have put in capsular hooks, they would have put in CTRs, they would have done iris stretching, they would have put in iris devices. All of this they would have been exposed to, so that they're not going to be in any way under any pressure to handle any kind of cataract wherever this person goes on. Thank you.
Really wonderful, sir. Like that fellow came out and went back in with the tip without injecting this. The feel of the tissue, feel of where the wound is, the depth, everything is so that the fellow has the real good feel of what is there in the 3D system. That's quite very evident. See, what is the feedback that you get from, like, you before you had this 3D system, you had fellows. After the 3D system, you have fellows. So I'm sure everyone is doing well going out. So who had the least amount of time to take off into being a top class surgeon when they went into practice?
Didn't make much of a difference, because two of my consultants now are my fellows who were with me earlier, who were trained with the regular microscope. And they are the best feedback that I get. They are coming back and telling me how fast the new fellows are picking up. Okay. So nothing that, I wouldn't say that the 3D is something that is absolutely essential, that you can't live without it. It does make it easier for you to teach. It makes it easier for the trainee to pick up nuances which are more difficult with the microscope. And personally, to me, it made my skills better. So it's something that, of course, there are flip side to it, is the expense one. Yeah. Two, the time taken is more. You can't have two tables, you'll have to one table. So you have to bring in a patient, take a patient out. So the time taken becomes more. So the time you spend in the OR becomes a little more, prolonged. Those are the cons of the whole system. But the pros are there. And it's brilliantly good for VR. Even better than for the cataract. So it's purely, I would look at the 3D as a training device and nothing else more. It's a fabulous training device. But if you want the person to get the full benefit of the training, the 100% training should be done on the 3D. And they just take it from there onto the microscope flawlessly. I have today, this morning, a short-term trainee joined, and he has been with us 1 year ago, done, and he's come back for a refresher course before he's starting his private practice. And he's straight off the bat today, 2 surgeries on 3D. He's never seen 3D before. And he's a good phacosurgeon. He's been with us earlier, but he's just coming for a refresher course. Off the bat, 2 surgeries on, and he went away.
That's wonderful.
That's again, we all think that there is a learning curve to 3D. No, I beg to disagree. The first 3D I ever did was on life surgery straight away in Sri Ganesh's place. He was inaugurating the microscope, and then I was called, and they said, do you want to try 3D? Yes, we'll try. And I found that not very difficult to take off. It was not difficult at all. And that's what made me buy the instrument.
But sir, you're up there, sir.
No, I'm talking about somebody who's never touched an eye.
Yeah.
Comes in and they start with 3D.
Yeah.
Believe me.
Yeah.
No. That's the beauty of the whole thing. No, we all think that you should learn handling tissue, then come to 3D. No, we're doing it the opposite way.
That's great. Like what I find really great about the training and Uma is that see, I get because people, these kids talk to me like, sir, I don't know how I have to go for surgical training. I have my practice. I can't leave it for long, and I have to come back and take care. And as I said, 3 years is quite a long time for them. But when I understand that in 1 year, you make them the real good phacosurgeons. And I would definitely recommend Sir's Institute to anybody.
Another point is, we have this tailor-made thing for people in practice already. they can come for as short as 1 week. 5 days or 6 days, Monday to Saturday, they would get to do about 10 to 14 cases. And if they are these people in practice are not raw persons. They are doing some kind of SICS at least.
Yes.
Or they're doing FACOs and having difficulty. So for them, that 10 to 14 cases is good enough to go back and start off on routine FACOs. So after 6 months or a year, they come back for another 1 week where they do the difficult cases. If they make 2 or 3 visits over about 6 months to 1 year, they'll become very accomplished surgeons in their practice. So they have to take only short periods off from the practice and come over.
No, this is really good, sir. Like this is information for me, because see, I advise them, you buy a machine and then they'll get you for training and all. So if such a training facility is available, it's a great boon for all these young fellows who are into practice and they can't take off time for long-term fellowship. And I'm absolutely sure that you're training them really well. This is good, sir. Like I'm really glad that you joined our program, and the kids are going to.
And all the 1-year fellows have to compulsorily have 1 publication minimum. We encourage to go for presentations. If it's within India, we bear the cost. Of course, abroad we cannot. And publication is a must. We're very particular. The day they join, they have to start working on a publication, and they have to finish it within 6 or 9 months. So they can't quit and go. At the end of 1 year, they should have got a publication in.
Yeah, how many people from Kerala have come and trained with you?
Quite a few. Offhand, I can't. It's quite a big number. But I have got a lot of people from Kerala who come and done the short period, 1 week, 2 week courses, plenty.
Okay. So no, I didn't really know about this. I'm glad that because I keep talking and I keep advising these kids, so they keep calling me for advice, and so this is.
By the way, Srini, you're a well-known person. How is it if you're not well-known? I have your number on my phone.
Yeah, no. I didn't really know, sir.
I knew who it was calling me when you called me. I didn't have to have any doubt. You're not somebody who's not known. Come on.
Sir,
my phone book.
Yeah, sir, we have Nivean with us.
Yeah.
My brother, see, he is another person who has got a lot of fellows from Kerala. As we all know,
over the world, he's got people from all over the world.
Yeah, Mongolia also. Yeah, I was telling, I'll talk about Mongolia when it presents. But see, basically, I'm doing.
Nivean is the main competitor for foreign trainees.
Yeah, I know. See, like, I am doing this program basically for young ophthalmologists in Kerala. But see, the kids from across India are seeing, like, the first episode already is reaching about 1,400 views. Like, so many people have seen. The second is reaching about 1,000 views. So Nivean, really happy to have you with us, and I'm sure, like, with you having so many overseas trainees, that's basically because your training program is so good. It's well structured, and also Nivean, please explain to us what you do with the trainees in your institute.
Yes, sir. So at the outset, I think I should really thank Dr. Singh for having this wonderful program, first of all, and a 3-part series along with the KSOS. As he said, his whole intention and this thing was to train the future generation. So that itself explains that's a huge step as far as ophthalmology is concerned. And I'll just keep it very short because I'm the last presenter and everybody's already explained in detail about the structure. So as your name suggests, learning and perfecting cataract surgery, in the last 1.5 hours, I have learned a lot. So that is one of the basic idea for any training program, that there is always some take-home points to learn and we should be keen on learning them. So that is what I try to tell the youngsters. It is always there and people are there to teach, but then it is their mindset. I think the first thing that they have to change is their mindset, because once you come with a open mind and the willingness to learn and not stuck to certain ideologies, I think there is always scope to become better and improve. So as I said, I'm just going to keep it very short, sir, just 2 slides. So because all my previous speakers have told in detail, so we also been doing the training for more than 15 years now. And then we basically have both the short-term program, which is basically a 1-month course, but it can be extended depending on the number of cases. So we basically do the small incision cataract surgery and the phaco training. And then we have the long-term fellowship, which has been 18 months, but that's been revised in the last 3 years. Initially, it was 1 year. So what differently we are doing alone, I'm going to highlight, because why we made it 18 months is, as all of them have spoken, it takes 1 year to actually train them and they are competent enough. So that is good. But the last 6 months is when actually they start doing things on their own. And this trainee becomes the trainer for the next fellow. So that is something different that we have started, because once that responsibility is given to them, they become better surgeons and they become more confident. And then, as all the speakers have said, when they have a complication, there's always somebody looking to take over and to manage, because the patient at the end of the day is very important for everybody. So here now he becomes competent in managing the complications and dealing. So there is an extra effort that is put by them. So that is why we are emphasized on the 18-month program. Yes, we do have all the specialities. But what I used to call this is a combo fellowship, because everybody wants to do cataract, and I think everybody should know how to do cataract. So I don't keep it as a separate fellowship. They can always choose one specialty of choice. So this is again going through all the specialties and fellowships, that if you're doing one thing, then coming out after so many years and then again getting trained in cataract. So my idea and aim was to have a combo fellowship where cataract is common for all the specialties, where they get trained in SICS if they're not done before. But if they're done before, then they shift on to phaco. So we have all the specialty. Yes, we also have the wet lab training. So as they join, they initially do the wet lab. But if they've already done surgeries, we don't insist on the wet lab because it is not going to be helpful for them. So we start off directly, but it is a stepwise program. Yes, surgical audit is very important, which we have on a monthly basis. And I tell them it is basically to make them better. It is not for me to criticize or to find fault in anybody. But unless we analyze our data, we do not know where we stand. So if we're having a score of 1 to 10, getting a score is not important. What we should see is how we have improved over time. So I tell them in 1 month, we break it down into 4 weeks. So each week, you see the next week if you're getting better. So that is the whole concept, because at last, once you finish a month, you don't know where you started and where you stand. So the scoring systems and audit weekly reviews are very important for any training. And recording, yes, I think everybody has emphasized it. Initially, these things were very expensive and not approachable, but now I think everything is available for recording. So that is why now recording has become a very key thing, even for me. Even I had a recent PCR in a PPC case, but I didn't know which step. Only when I played back the video, we understood how the hydrodelineation actually became a dissection. It might be a small thing, but then you can actually find out where you've gone wrong. And again, it is only to correct yourself, because sometimes when you're doing under a lot of pressure as beginners, our mind always concentrates on only one step. Like I've seen so many times, for example, when you're doing phaco, they really don't know where the second hand is going. So most of the time, it is the second instrument that goes and tears the anterior capsule or the iris, because they usually say the pupil becomes small. So all these things can be found out and rectified. See, the best part is when you start seeing your videos, you start liking it, and then you start to rectify it. And as already Dr. Arulmozhi sir has already told, so 3D is something that is new, has come into our setup also. And basically right now, they are not doing it on 3D, but they're learning it from 3D. So it is actually a very good tool, as he says, because of the depth, to explain to them about the cracking, the depth, the groove, certain principles. It is really very useful. And follow up, as others have also said, once the trainees finishes and go, we do not stop there. We still continue the relationship, because at any point of time, they can always contact us if they're having a problem with the case or any doubts. And that's how we both learn together. And they're always come back again. So we always had, as I think Mahesh sir told first, that you cannot learn everything in 1 month. So that's a wrong concept. So we can only teach you the steps. So go back to your practice and then start doing it on a regular basis. And that is when individually you will find difficulties which are not there, because here you always have a trainer with you. So once you have that, we always ask them to note it down. So they can always come back after 6 months. So we do not tell them that you can become an expert in 2 months or 1 month. So you can always come back after 6 months and do a shorter course where only the key problems that you have are addressed. So this way they are also happy, and they also learn faster. And that rapport is also kept with us to continue forward. So just to divert from all the others, because they already told how the structured program is, because I was fantasized by like how systematic and protocol oriented all the training programs were. So there are certain things that we expect from the trainee side also. So we always want them to come with a holistic approach, because nowadays the newer generation or the next generation are more interested only in the surgical or what they call as a cutting thing, which I don't agree with, because we should see the patient as a whole. At the end of the day, we are doctors and ophthalmologists. So it is not only about the surgery that is going to make you better, is something that they try to emphasize. And as training institutes, we all know we get these patients from only the camps or the outreach programs. And we know there's a lot of manpower, effort, and expense involved in this. So basically, they should not take the patients for granted, because we are having an opportunity to learn from these patients' side. Because if the patient can afford, I usually tell them they have the choice of any good hospital where they can go and they get the best of the service. So when there is somebody in needy and they're actually coming to you, your responsibility becomes more in providing them good vision, because their whole life depends on this, and it is not about just doing the surgery and going out. So this emphasis also should go to all the trainees, and they're also part of this. At last, I think all the hospitals across India you have got here, so all of them working towards the same cause of eradicating needless blindness. And I think each surgeon that is doing is also a part of this big program. Actually, they are also helping. So there is a bigger cost that is also involved. So the main 5 key things that we pay attention is pre-op evaluation, because they have to see the patients before to know the grade of cataract, the dilatation, the iris structure. So all this helps them to plan intraoperatively. And also we have found out that even going one step further of how to do the IOL power calculation or a simple biometry, because we've seen most of them previously when they go back to the practice, then they come up with these questions. So nowadays they get involved in the workup of the patient. So how the patient is worked up, how all these things are done. So this gives them an opportunity to learn how it can be done. So I understand only if you know it, I think you can teach somebody else. So when you go back to your practice, you will know something that you can find out if your optometrist or somebody else has done some error in the A scan, and that is going to lead to a surprise. So there is no. So these are things that we take pre-operatively. Intraoperatively, yes, there is always somebody watching there to help and assist. And we try to stop before the complication occurs, because some complications can be managed. As a VR surgeon, I know, and some of them we know that are very difficult to manage and might lead to poor visual outcomes. And also the recording as far as intraoperative procedures are concerned. Post-op is also very important, because when I was in Aravind, I think I learned a lot. They say that Nachar madam used to say, by just seeing the post-operative picture of an operated patient, you can describe the entire thing that went intraoperatively. Maybe at that particular time, I could not understand, but now I understand, because she knows how many times I have touched the iris, how just looking at the shape of the iris, or also the type of edema in the cornea. So you can have a central edema, or you can have something in this way. So you can actually predict whether it was due to the instrument touch or it was due to nucleus delivery. So these things, when you look at the post-op and you try to relate to what happened intraoperative, you turn to learn. And then how do you correct? Even the section, the lip of the section, like how the inner lip is, outer lip is, these might be small things. But unless you pay attention to post-operative care and drawing the diagram post-operative, it is not just saying everything is fine, good, go. How you draw the diagram, because I have very emphasized them that the diagram should be exactly what you see, not always round pupils and then fine cornea clear. It should be exactly, if it is irregular or a D-shaped, you draw that, because then you will understand why you caused the D-shaped pupil. So I think post-op and follow-up, because in that 1 month when the patient comes back for follow-up, we ask them to follow up again for them to learn how the refractive error of these things over time in a SACS or a phaco case, and when you have to intervene on the next time to the patient, whether there is some stage where you have an optic capture or you have some vitreous in the AC, and when do you have to intervene. So when you follow up your patients, you also learn other things that may be useful for your private practice. And all this is done basically to identify what has you have to change. And unless you're willing to accept that change and then apply it in the next case, because each patient is very important for us, for any organization, because it is those patients that are going out, and then the more patients come into the organization. So it is good to have 100 happy patients, but nobody criticizes. But then that one unhappy patient can bring down the entire institute, as far as I am concerned. So giving that attention to details to every patient, and willing to change your technique or something that could make the next surgery better. So that is how you learn. So I think that's all. I have only these 2 slides, so to keep it short and sweet. But to conclude, I would also like to say that what I've learned through this webinar, Shreeni sir, to make your work a little easier, because Dr. Smita ma'am started with a brilliant overview. So I like to think about that the numbers don't matter, because most of them are fixed with numbers. Can I do this many cases, that many cases? So numbers don't matter. It is actually the concepts that are very important, because trained in Shankar Nethralaya, we will not, even though we had that thing of we got lesser cases as a VR surgeon, but then the concepts were very clear. So if your concepts are very clear and if you apply them in your clinical practice, everybody will become a better surgeon. You just have to give time. And time is also a very important thing that you cannot, I think Mahesa said that there's no shortcuts. So time also has to be given. Overnight, you cannot become a great surgeon. And then Dr. Sima from Shroff told about the organization culture and values. So that is another important thing. When people come and get trained under us, they actually go through the cultures and value of that organization and what is the core competency that has brought up that organization. So they get to learn that. And that is also something they can take back. It is not only what is happening inside the OR, it is something that goes around outside. And being fortunate to be in any of the institute, I think you can take home certain points from that. And then Dr. Shreya showed beautiful videos of the entire presentation. And I like the orientation program of the touring of the hospitals and interacting with other departments. Because again, as I said, it is not just that one department cataract, there are multiple departments involved, whether there's an intraocular pressure raise, the glaucoma, retina. So then you should know the other departments and how everybody functions as a teamwork. LVPEI, I think Dr. Vivek, no comments. I think we have a long way to go. He was almost like a superhero, but the one thing that he said is the bigger you grow, the more responsibilities. And that is very, very true. Everybody wants to grow, but then I think the responsibilities also grow. And last, closing with Arulmozhi sir, I am a very big fan of his phaco, like you, Srini sir. Like you just get amazed looking at him and how easy he makes surgery. And me also, when I was finding it difficult to shift from stop and chop to direct chop, I think he was the one who actually taught me. So again, there is no, you can always keep learning even in your practice, even after you've done after 2000 surgeries. And then it was his technique and his ideologies and physics. He's a master of physics when it comes. So unless you learn the dynamics of what happens in the phaco, so that actually made me a better chop surgeon, and thanks to him. So I think everybody plays a role and the learning continues. So once again, thanks Srini sir for this wonderful program, and my teachers from around the eye care system and Shankar Nethralaya for making me who I am. Thank you, sir.
Thank you, Nivean, for giving the viewers an overview of whatever happened today. And it's been a great learning process for me. Like I've been in this for three episodes. I might do one more, and I've learned. I've seen the passion of each and every one of the teachers. Dr. Paneerselvam sir, like he was the one who made me change the whole program. He said, Sreeni, see these surgical videos, they'll see everywhere. I'm going to tell about the responsibilities of the trainer, responsibility of the trainee, and all. Then I was initially going to do it with SICs only. Then I told everyone from office and Arvind, everyone that said we'll just concentrate on the training aspects, the whole training aspects of cataract surgery, and it's been wonderful. And thanks to all of you. Now these young ophthalmologists have a forum where they can actually compare between the training in LVPEI, Arvind, Uma, M, and everywhere. And see, each person will have a different need. So, as Arulmozhi sir said, there are a lot of people who can't take off for a year from their practice, and they have Uma where you can go for 1 week, then get trained, then go back. So effectively a sandwich program. So we have different training modules in different institutes, and each of this institute can actually learn from the other institute. So it has been a wonderful learning opportunity for me. Thank you, Arulmozhi sir, Nivean, Shreya, Smita, Dr. Vivek, everyone. Thanks a lot. We'll end this program now, and thanks a lot once again.
Thanks you. Good night.
Thanks a lot from KSOS side. Thank you.
Thank you, Srini sir.
Bye. Dr. Vivek, bye.